pernicious anemia. Vitamin B12 deficiency causes macrocytic anemia with large red blood cells. The key causes of a low vitamin B12 are pernicious anemia, insufficient dietary B12, for example on a vegan diet as B12 is mostly found in animal products, and medications that reduce B12 absorption, for example proton pump inhibitors and metformin. Pernicious anemia is an autoimmune condition involving antibodies against the parietal cells or intrinsic factor. So let's talk in more detail about the pathophysiology of pernicious anemia. The parietal cells of the stomach produce a protein called intrinsic factor. Intrinsic factor is essential for the absorption of vitamin B12 in the distal ileum. In pernicious anemia, autoantibodies target either the parietal cells or intrinsic factor, resulting in a lack of intrinsic factor and a lack of absorption of vitamin B12. Vitamin B12 deficiency can cause neurological symptoms, such as peripheral neuropathy with numbness or paresthesia or pins and needles, a loss of vibration sense, a loss of proprioception, visual changes, and mood and cognitive changes. A Tom tip for you: for your exams, remember to test for a vitamin B12 deficiency and pernicious anemia in patients presenting with peripheral neuropathy, particularly with pins and needles in the hands and feet. Next, let's talk about autoantibodies. Autoantibodies used to diagnose pernicious anemia are intrinsic factor antibodies, which are the first-line investigation, and gastric parietal cell antibodies. However, these tend to be less helpful. Finally, let's talk about management. The information here is based on the NICE clinical knowledge summaries updated in 2023. Check the latest guidelines before treating patients. Intramuscular hydroxycobalamin is initially given to all patients with B12 deficiency, depending on the symptoms. If there's no neurological symptoms, it's given 3 times weekly for 2 weeks. And if there are neurological symptoms, it's given on alternate days until there's no further improvement in symptoms. Maintenance depends on the cause. With pernicious anemia, they require 2 to 3 monthly injections for life. If it's diet-related, the options for maintenance include oral cyanocobalamin or twice-yearly injections. Where there is B12 and folate deficiency together, it's essential to treat the B12 deficiency first before correcting the folate deficiency. Giving patients folic acid when they have a B12 deficiency can lead to subacute combined degeneration of the cord, with demyelination in the spinal cord and severe neurological problems. Chapter 82: Hemolytic Anemia. Hemolytic anemia involves the destruction of red blood cells, which is called hemolysis, and this results in a low hemoglobin concentration, which is called anemia. Several inherited conditions can cause the red blood cells to become more fragile and break down faster than normal, leading to chronic hemolytic anemia. And these inherited conditions include hereditary spherocytosis, hereditary elliptocytosis, thalassemia, sickle cell anemia, and G6PD deficiency. Several acquired conditions, which the patient develops during their lifetime, can lead to the destruction of red blood cells, including autoimmune hemolytic anemia, alloimmune hemolytic anemia, for example, transfusion reactions and hemolytic disease of the newborn, paroxysmal nocturnal hemoglobinuria, microangiopathic hemolytic anemia, and prosthetic valve-related hemolysis. These all sound very intimidating, but we're going to go through each one in detail to explain it simply. Let's start by talking about the features of hemolytic anemia. The features are a result of the destruction of red blood cells, including anemia, or a low hemoglobin concentration, splenomegaly, where the spleen becomes filled with the destroyed red blood cells, and jaundice, where bilirubin is contained within red blood cells and released when they're destroyed. Next, let's talk about the key investigation results. A full blood count will show a normocytic anemia with red blood cells that are normal sized. A blood film shows schistocytes, which are fragments of red blood cells. And the direct Coombs test is positive in autoimmune hemolytic anemia, but not in the other types of hemolytic anemia. Let's talk in more detail about hereditary spherocytosis. Hereditary spherocytosis is the most common inherited hemolytic anemia in Northern Europeans. It's an autosomal dominant condition. It causes fragile, sphere-shaped red blood cells that easily break down when they're passing through the spleen. It presents with anemia, jaundice, gallstones, and splenomegaly. A notable feature is aplastic crisis in the presence of parvovirus. There's likely a positive family history as it's an autosomal dominant condition. Key findings in hereditary spherocytosis are a raised mean corpuscular hemoglobin concentration, or MCHC, on a full blood count, a raised reticulocyte count due to a rapid turnover of red blood cells, and spherocytes on a blood film. Treatment of hereditary spherocytosis is with folate supplementation, blood transfusions when required, and splenectomy, or removal of the spleen. Gallbladder removal or a cholecystectomy may be required if gallstones are a problem. Next, let's talk about hereditary elliptocytosis. Hereditary elliptocytosis is similar to hereditary spherocytosis, except that the red blood cells are ellipse-shaped. It's also autosomal dominant, and the presentation and management are the same as hereditary spherocytosis. Next, let's talk about G6PD deficiency. G6PD deficiency is caused by a defect in the gene that codes for glucose 6-phosphate dehydrogenase, or G6PD, which is an enzyme responsible for protecting cells from oxidative damage. It's an X-linked recessive genetic condition, meaning that males are much more often affected than females, and females are carriers as they have 2 X chromosomes. It's more common in Mediterranean, Asian, and African patients. G6PD deficiency results in acute episodes of hemolytic anemia triggered by infections, drugs, or fava beans. Key medications include ciprofloxacin, sulfonylureas, for example gliclazide, and sulfasalazine. It presents with jaundice, often in the neonatal period shortly after birth, gallstones, anemia, splenomegaly, and Heinz bodies on a blood film. Diagnosis can be made by doing a G6PD enzyme assay. A Tom tip for you, a critical piece of knowledge for G6PD deficiency relates to triggers. In your exams, look out for a male patient that turns jaundice and becomes anemic after eating fava beans or broad beans, developing an infection, or taking antimalarials. In this scenario, the underlying diagnosis is probably G6PD deficiency. Next, let's talk about autoimmune hemolytic anemia. Autoimmune hemolytic anemia occurs when antibodies are created against the patient's own red blood cells. these antibodies lead to red blood cell destruction, or hemolysis. There are two types of autoimmune hemolytic anemia, warm and cold, based on the temperature at which the autoantibodies destroy red blood cells. Warm type autoimmune hemolytic anemia is the more common type. Hemolysis occurs at normal or above normal temperatures. Warm autoimmune hemolytic anemia is usually idiopathic, meaning that it arises without a clear cause. Cold reactive autoimmune hemolytic anemia is also called cold agglutinin disease. At lower temperatures, for example less than 10 degrees Celsius, the antibodies attach to red blood cells and cause them to clump together, and this is called agglutination. The immune system is activated and the red blood cells are destroyed. Cold reactive autoimmune hemolytic anemia can be secondary to lymphoma, leukemia, systemic lupus erythematosus, and infections such as mycoplasma, Epstein-Barr virus, cytomegalovirus, and HIV. Management of autoimmune hemolytic anemia involves blood transfusions, prednisolone or steroids, rituximab, which is a monoclonal antibody against B cells, and splenectomy. Next, let's talk about alloimmune hemolytic anemia. Alloimmune hemolytic anemia occurs due to the presence of foreign red blood cells or foreign antibodies. The two scenarios where this happens are transfusion reactions and hemolytic disease of the newborn. Hemolytic transfusion reactions occur when red blood cells are transfused into the patient. The immune system produces antibodies against the antigens on the foreign red blood cells. An immune reaction leads to destruction of those foreign red blood cells. Hemolytic disease of the newborn occurs when maternal antibodies, or antibodies from the mother, cross the placenta into the fetus. These maternal antibodies target antigens on the red blood cells of the fetus. The maternal antibodies lead to destruction of the neonate's red blood cells. This occurs when the fetus is rhesus D positive with rhesus D antigens on their red blood cells, and the mother is rhesus D negative with no rhesus D antigens on her red blood cells. During a sensitization event, for example antepartum hemorrhage or bleeding during pregnancy, the mother can get exposed to the fetal red blood cells and start producing anti-D antibodies against the rhesus D antigen. Then in future, these antibodies can cross through the placenta to the baby and cause hemolysis or destruction of the baby's red blood cells. Sensitization is prevented in rhesus-negative women by using anti-D prophylaxis. Next, let's talk about paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria is caused by a specific genetic mutation in the hematopoietic stem cells in the bone marrow. This mutation occurs during the patient's lifetime, as opposed to being an inherited genetic condition. It results in a loss of the proteins on the surface of red blood cells that inhibit the complement cascade, and this allows activation of the complement cascade on red blood cells and subsequently their destruction. The characteristic presenting symptom of paroxysmal nocturnal hemoglobinuria is red urine in the morning, and this contains hemoglobin and hemosiderin. Other presenting features are anemia, thrombosis, for example DVTs, PEs, and hepatic vein thrombosis, and smooth muscle dystonia, for example esophageal spasm and erectile dysfunction. Management is with eculizumab or bone marrow transplantation. Eculizumab is a monoclonal antibody that targets complement component 5 or C5. Bone marrow transplantation can potentially be curative. Next, let's talk about microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia, or MAHA, involves the destruction of red blood cells as they travel through the circulation. This is most often caused by abnormal activation of the clotting system, with blood clots or thrombi partially obstructing the small blood vessels, and this is referred to as thrombotic microangiopathy. These obstructions within the blood vessels churn up the red blood cells, causing hemolysis, or rupture. You can picture this as a mesh formed inside small blood vessels shredding up the red blood cells. Microangiopathic hemolytic anemia, or MAHA, is usually secondary to an underlying condition, such as hemolytic uremic syndrome, or HUS, disseminated intravascular coagulation, or DIC, thrombotic thrombocytopenic purpura, or TTP, systemic lupus erythematosus, or SLE, or cancer. Schistocytes are a key finding on the blood film in patients with microangiopathic hemolytic anemia. Finally, let's talk about prosthetic valve hemolysis. Hemolytic anemia is a key complication of prosthetic heart valves. It can occur in both bioprosthetic and metallic valve replacement, although it does vary depending on the type. Hemolysis is caused by turbulent flow around the valve and the shearing of the red blood cells. The valve essentially churns up the cells and the cells break down. Management of prosthetic valve hemolysis involves monitoring, oral iron and folic acid supplementation, blood transfusions if severe, and valve revision surgery may be required in severe cases. Chapter 83: Thalassemia. Thalassemia is caused by a genetic defect in the carrier proteins that make up hemoglobin. Normal hemoglobin consists of 2 alpha-globin and 2 beta-globin chains. Defects in alpha-globin chains lead to alpha thalassemia, and defects in the beta-globin chains lead to beta thalassemia. Both conditions are autosomal recessive. The overall effect is varying degrees of anemia depending on the type and the mutation. In patients with thalassemia, the red blood cells are more fragile and they break down more easily, causing hemolytic anemia. The spleen acts like a sieve, filtering the blood and removing old cells. The spleen in thalassemia collects all the destroyed red blood cells, and this results in splenomegaly, as the spleen enlarges full of all the destroyed red blood cells. Let's go through the features. The severity of features depends on the type of thalassemia. Universal features include a microcytic anemia with small red blood cells, fatigue, pallor or pale skin, jaundice, gallstones, splenomegaly or an enlarged spleen, and poor growth and development in children. Next, let's talk about the investigations. Microcytic anemia, where there's a low mean corpuscular volume, is a typical finding on a full blood count. Raised ferritin suggests iron overload, which is a common complication that we'll talk about in more detail shortly. Hemoglobin electrophoresis is used to diagnose globin abnormalities. DNA testing can be used to look for the genetic abnormality. All pregnant women in the UK are offered a screening test for thalassemia at the Booking Clinic. So let's talk in more detail about iron overload. Iron overload may occur in thalassemia due to increased iron absorption in the gastrointestinal tract and blood transfusions. Iron overload in thalassemia can cause symptoms and complications of liver cirrhosis, hypogonadism, with low levels of the sex hormones, hypothyroidism, with low levels of the thyroid hormones, heart failure, diabetes, and osteoporosis. Serum ferritin levels are closely monitored. Management of iron overload involves limiting transfusions and iron chelation. Let's talk in more detail about alpha thalassemia. Defects in the alpha globin chains cause alpha thalassemia. The genes that code for alpha globin are found on chromosome 16. The severity of symptoms varies depending on the type and the number of genetic defects, ranging from entirely asymptomatic as a carrier to moderate anemia, which is called hemoglobin H disease, to intrauterine death due to severe fetal anemia in alpha thalassemia major. Management of alpha thalassemia involves monitoring, blood transfusions where required, splenectomy may be performed, and bone marrow transplant may be curative. Next, let's talk about beta thalassemia. Defects in beta globin chains cause beta thalassemia. The gene coding for this protein is on chromosome 11. The gene defects can either consist of abnormal copies that retain some function or deletion genes with no function in beta globin. Based on the type of genetic defects, beta thalassemia can be split into three types: thalassemia minor, thalassemia intermedia, and thalassemia major. Let's talk in more detail about thalassemia minor. Patients with beta thalassemia minor, also called thalassemia trait, are carriers of an abnormally functioning beta globin gene. They have one normal gene and one abnormal gene. Thalassemia minor causes mild microcytic anemia, which usually only requires monitoring. Let's talk about thalassemia intermedia. Patients with beta thalassemia intermedia have two abnormal copies of the beta globin gene. This can be either two defective genes or one defective gene and one deletion gene. Thalassemia intermedia causes more significant microcytic anemia. Patients require monitoring and may need occasional blood transfusions. They may also need iron chelation to prevent iron overload. Finally, let's talk about thalassemia major. Patients with beta thalassemia major are homozygous for the deletion genes, meaning that they have no functioning beta globin genes. This is the most severe form and usually presents with severe anemia and failure to thrive in childhood. In thalassemia major, the bone marrow is under so much strain to produce extra red blood cells to compensate for the chronic anemia that it expands enough to increase the risk of fractures and change the patient's appearance. Abnormal features relating to bone changes include frontal bossing with a prominent forehead, enlarged maxilla with prominent cheekbones, a depressed nasal bridge or a flat nose, and protruding upper teeth. Management of thalassemia major involves regular blood transfusions, iron chelation, and splenectomy. A bone marrow transplant can be curative. Chapter 84: Sickle Cell Disease. Sickle cell anemia is a genetic condition that causes sickle or crescent-shaped red blood cells. The abnormal shape makes the red blood cells more fragile and easily destroyed, leading to hemolytic anemia, where the red blood cells break down. Patients with sickle cell anemia are prone to various sickle cell crises, which we'll talk about in more detail later on. Let's start with the pathophysiology. Hemoglobin is the protein in red blood cells that transports oxygen. Oxygen attaches to the hemoglobin molecule and is delivered around the body. During fetal development at around 32 to 36 weeks of pregnancy, fetal hemoglobin, or HbF, production decreases, and adult hemoglobin, or HbA, increases. So the fetal hemoglobin is gradually replaced with adult hemoglobin. At birth, around half the hemoglobin is fetal hemoglobin and half is adult hemoglobin. By 6 months of age, very little fetal hemoglobin is produced and the red blood cells contain almost entirely adult hemoglobin. Patients with sickle cell disease have an abnormal variant called hemoglobin S, or HbS. Hemoglobin S results in sickle-shaped red blood cells. Sickle cell anemia is an autosomal recessive condition affecting the gene for beta-globin on chromosome 11. One abnormal copy of the gene results in sickle cell trait. Patients with sickle cell trait are usually asymptomatic, meaning they have no symptoms. Patients with one abnormal copy are defined as carriers of the condition, so they carry the abnormal gene but they're not affected by the disease. 2 abnormal copies result in sickle cell disease. Let's talk about the relationship with sickle cell disease and malaria. Sickle cell disease is more common in patients from areas traditionally affected by malaria, such as Africa, India, the Middle East, and the Caribbean. Having one abnormal copy of the gene, or being sickle cell trait or a carrier of the condition, reduces the severity of malaria infection. As a result, patients with sickle cell trait are more likely to survive malaria and pass on their genes. Therefore, there is a selective advantage to having the sickle cell gene in areas of malaria, making it more common. Let's talk about screening. In the UK, sickle cell disease is tested for on the newborn blood spot screening test at around 5 days of age, so it's usually picked up shortly after birth. Pregnant women that are at high risk of being carriers of the sickle cell gene are offered testing. Let's go through the complications. The complications of sickle cell disease are anemia, increased risk of infection, chronic kidney disease, sickle cell crises, which we'll talk about in more detail, acute chest syndrome, which we'll also talk about in more detail, stroke, avascular necrosis or death of the bone due to insufficient blood supply in large joints such as the hip, pulmonary hypertension, gallstones, and priapism, which is painful and persistent penile erections. So let's talk about sickle cell crisis. Sickle cell crisis refers to a spectrum of acute exacerbations caused by sickle cell disease, and these range from mild to life-threatening. They can occur spontaneously or can be triggered by dehydration, infection, stress, or cold weather. There's no specific treatment for sickle cell crisis, and the management is mainly supportive, with low threshold for admission to hospital, treating infections that may have triggered the crisis, keeping the patient warm, good hydration, and this may involve IV fluids, and analgesia, except non-steroidal anti-inflammatory drugs or NSAIDs should be avoided where there is renal impairment. So let's go through some of the specific types of crisis, starting with vaso-occlusive crisis. Vaso-occlusive crisis is also known as painful crisis, and it's the most common type of sickle cell crisis. It's caused by the sickle-shaped red blood cells clogging up capillaries, causing ischemia to the tissue that's distal to those capillaries. Essentially, the small blood vessels get clogged up with red blood cells, and oxygen can't be delivered to the tissues that those blood vessels supply. Vaso-occlusive crisis typically presents with pain and swelling in the hands or feet, but it can affect the chest, back, and other body areas. It can be associated with a fever. Vaso-occlusive crisis can cause priapism in men by trapping blood in the penis, causing a painful and persistent erection. And this is a urological emergency that's treated by aspirating blood from the penis. Next, let's talk about splenic sequestration crisis. Splenic sequestration crisis is caused by red blood cells blocking blood flow within the spleen. This causes an acutely enlarged and painful spleen. Blood pooling in the spleen can lead to severe anemia and hypovolemic shock because there's not enough blood volume in other areas of the body. Splenic sequestration crisis is considered an emergency. The management is supportive with blood transfusions and fluid resuscitation to treat anemia and shock. Splenic sequestration crisis can lead to splenic infarction, where there's death of the spleen tissue, leading to hyposplenism or underfunctioning of the spleen and susceptibility to infections, particularly infections caused by encapsulated bacteria, for example, Streptococcus pneumoniae and Haemophilus influenzae. Splenectomy, or removal of the spleen, prevents splenic sequestration crisis and may be used in recurrent cases. Next, let's talk about aplastic crisis. Aplastic crisis describes a temporary absence of the creation of new red blood cells, and this is usually triggered by infection with parvovirus B19. Aplastic crisis leads to significant anemia, specifically aplastic anemia, where there's no red blood cells being created. Management is supportive with blood transfusions if necessary. Aplastic crisis usually resolves spontaneously within around a week. Next, let's talk about acute chest syndrome. Acute chest syndrome occurs when the vessels supplying the lungs become clogged up with red blood cells. This can be triggered by a vaso-occlusive crisis, fat embolism, or infection. Acute chest syndrome presents with fever, shortness of breath, chest pain, cough, and hypoxia, or low oxygen levels. A chest X-ray will show pulmonary infiltrates. Acute chest syndrome is a medical emergency and it's got a high mortality, so it requires prompt supportive management and treatment of the underlying cause, with analgesia to treat pain, good hydration with intravenous fluids if required, antibiotics or antiviral drugs for infections, blood transfusions to treat anemia. Incentive spirometry involves using a machine that encourages effective and deep breathing, and respiratory support with oxygen, non-invasive ventilation, or mechanical ventilation if required. Finally, let's talk about the general management of sickle cell disease. A specialist multidisciplinary team will manage the disease. The general principles are to avoid triggers for crises such as dehydration, have up-to-date vaccinations, antibiotic prophylaxis is used to protect against infection, typically with penicillin V or phenoxymethyl penicillin. Hydroxycarbamide may be used, and this stimulates the production of fetal hemoglobin instead of adult hemoglobin. Crizanlizumab, which is a monoclonal antibody that targets P-selectin. Blood transfusions for severe anemia, and a bone marrow transplant can be curative but carries significant risks. Hydroxycarbamide works by stimulating the production of fetal hemoglobin. Fetal hemoglobin does not lead to sickling of the red blood cells, unlike hemoglobin S. Hydroxycarbamide reduces the frequency of vaso-occlusive crises, improves anemia, and may extend lifespan. Crizanlizumab is a monoclonal antibody that targets P-selectin. P-selectin is an adhesion molecule found on endothelial cells on the inside walls of blood vessels and on platelets. By targeting and interfering with P-selectin, it prevents red blood cells from sticking to the blood vessel wall and reduces the frequency of vaso-occlusive crises. Chapter 85: Leukemia. Leukemia is cancer of a particular line of stem cells in the bone marrow, causing unregulated production of a specific type of blood cell. Let's talk about the types. The types of leukemia can be classified depending on how rapidly they progress, where chronic is slow and acute is fast, and the cell line that is affected, generally myeloid or lymphoid cell lines. And this makes the 4 types of leukemia: acute myeloid leukemia, where there's rapidly progressing cancer of the myeloid cell line; acute lymphoblastic leukemia, where there's rapidly progressing cancer of the lymphoid cell line; chronic myeloid leukemia, where there's slowly progressing cancer of the myeloid cell line; and chronic lymphocytic leukemia, where there's slowly progressing cancer of the lymphoid cell line. Other rarer types of leukemia, such as acute promyelocytic leukemia, are less likely to appear in your exams. Most types of leukemia occur in patients over 60 to 70 years of age. The exception is acute lymphoblastic leukemia, which most commonly affects children under 5 years of age. A Tom tip for you: the key differentiating features to remember for exams are acute lymphoblastic leukemia is the most common leukemia in children and is associated with Down syndrome. Chronic lymphocytic leukemia is associated with warm hemolytic anemia, Richter's transformation, and smudge cells. Chronic myeloid leukemia has 3 phases, including a long chronic phase, and is associated with the Philadelphia chromosome. And acute myeloid leukemia may result in a transformation from a myeloproliferative disorder and is associated with Ayer-Rhod's. Let's talk about the pathophysiology. A genetic mutation in one of the precursor cells in the bone marrow leads to excessive production of a single type of abnormal white blood cell. The excessive production of a single type of cell can suppress the other cell lines, causing the underproduction of different cell types. This can result in pancytopenia, which is a combination of low red blood cells, or anemia, low white blood cells, or leukopenia, and low platelets, which is thrombocytopenia. Next, let's talk about the presentation. The presentation of leukemia is relatively nonspecific. An urgent full blood count is required when leukemia is suspected as a differential diagnosis. Potential presenting features include fatigue, fever, pallor or pale skin due to anemia, petechiae or bruising due to thrombocytopenia or low platelets, abnormal bleeding, lymphadenopathy or swollen abnormal lymph nodes, hepatosplenomegaly or an enlarged liver and spleen, and failure to thrive in children. Let's talk about petechiae and purpura. One key presenting feature of leukemia is bleeding under the skin due to thrombocytopenia or a low platelet count. Bleeding under the skin causes non-blanching lesions, meaning that if you put pressure on the lesions, they don't disappear or blanch. These lesions are called different things based on the size of the lesion. Petechiae are less than 3 mm and caused by burst capillaries. Purpura are 3 to 10 mm, and ecchymosis is larger than 1 centimeter. The top differentials for a non-blanching rash caused by bleeding under the skin are leukemia, meningococcal septicemia, vasculitis, Henoch-Schönlein purpura or HSP, immune thrombocytopenic purpura or ITP, thrombotic thrombocytopenic purpura or TTP, traumatic or mechanical injury, for example, severe vomiting, and non-accidental injury. Consider non-accidental injury or abuse as a differential, particularly in children and vulnerable adults. Let's talk about the diagnosis. The NICE guidelines on suspected cancer from 2021 recommend a full blood count within 48 hours for patients with suspected leukemia. They recommend children or young people with petechiae or hepatosplenomegaly are sent for immediate specialist assessment, meaning straight into hospital. A full blood count is the initial investigation. A blood film is used to look for abnormal cells and inclusions within those cells. Lactate dehydrogenase, or LDH, is a very non-specific marker of tissue damage, and it's often raised in leukemia, but also in other cancers and many non-cancerous conditions, including after heavy exercise. LDH is not helpful as a screening test, but may be used for specialist assessment and monitoring the condition. A bone marrow biopsy is used to analyze the cells in the bone marrow, and this is how a definitive diagnosis of leukemia is established. CT and PET scans may be used to help stage the condition. A lymph node biopsy can be used to assess abnormal lymph nodes. Genetic testing, looking for chromosomes and DNA changes, and immunophenotyping, looking for specific proteins on the surface of cells, may be performed to help guide treatment and prognosis. So let's talk in more detail about a bone marrow biopsy. Bone marrow biopsy is usually taken from the iliac crest above the hip. It involves a local anesthetic and a specialist needle. The options are aspiration or trephine. Bone marrow aspiration involves taking a liquid sample of the cells from within the bone marrow. Bone marrow trephine involves taking a solid core sample of the bone marrow and provides a better assessment of the cells and the structure. So let's talk in more detail about acute lymphoblastic leukemia. Acute lymphoblastic leukemia affects one of the lymphocyte precursor cells, causing acute proliferation of a single type of lymphocyte, usually B lymphocytes. Excessive accumulation of these cells replaces the other cell types within the bone marrow, and this causes a pancytopenia. Acute lymphoblastic leukemia most often affects children under the age of 5, but it can also affect older adults. It's more common with Down syndrome. Acute lymphoblastic leukemia can be associated with the Philadelphia chromosome, but this chromosome is more associated with chronic myeloid leukemia, which we'll talk about shortly. Let's talk in more detail about chronic lymphocytic leukemia. Chronic lymphocytic leukemia is where there is slow proliferation of a single type of well-differentiated lymphocyte, usually B lymphocytes. It usually affects adults over the age of 60. It's often asymptomatic, meaning there's no symptoms, but it can present with infections, anemia, bleeding, and weight loss. It may cause warm autoimmune hemolytic anemia. Richter's transformation refers to the rare transformation of chronic lymphocytic leukemia into high-grade B-cell lymphoma. Smear or smudge cells are ruptured white blood cells that occur while preparing the blood film when the cells are aged or fragile. Smear or smudge cells are particularly associated with chronic lymphocytic leukemia. Next, let's talk about chronic myeloid leukemia. Chronic myeloid leukemia has 3 phases: the chronic phase, the accelerated phase, and the blast phase. The chronic phase is often asymptomatic, and patients are diagnosed after an incidental finding of a raised white cell count on a full blood count. The chronic phase can last for several years before the disease progresses. The accelerated phase occurs when the abnormal blast cells take up a high proportion, 10 to 20%, of the bone marrow and the blood cells. In the accelerated phase, patients are more symptomatic and they can develop anemia, thrombocytopenia, and immunodeficiency. The blast phase follows the accelerated phase, and this involves an even higher proportion, over 20%, of the blast cells in the blood. The blast phase has severe symptoms and pancytopenia and is often fatal. Chronic myeloid leukemia is particularly associated with the Philadelphia chromosome. This refers to an abnormal chromosome 22 caused by a reciprocal translocation or a swap of genetic material between a section of chromosome 9 and chromosome 22. This translocation creates an abnormal gene sequence called BCR-ABL1, which codes for an abnormal tyrosine kinase enzyme that drives the proliferation of the abnormal cells. Next, let's talk about acute myeloid leukemia. There are many subtypes of acute myeloid leukemia with slightly different cytogenetics and presentations. Acute myeloid leukemia can present at any age, but normally presents from middle-aged onwards. It can occur from the transformation from a myeloproliferative disorder. For example, a patient who has polycythemia vera or myelofibrosis, those conditions can transform into acute myeloid leukemia. A blood film and bone marrow biopsy will show a high proportion of blast cells. Ayer rods in the cytoplasm of the blast cells are a characteristic finding of acute myeloid leukemia. Next, let's talk about the general management of leukemia. An oncology and hematology multidisciplinary team will coordinate treatment. Leukemia is mainly treated with chemotherapy and targeted therapies, depending on the type and the individual features. Examples of targeted therapies, which are mainly used in chronic lymphocytic leukemia, are tyrosine kinase inhibitors, for example, ibrutinib, and monoclonal antibodies, for example, rituximab, which targets B cells. Other treatment options include radiotherapy, bone marrow transplant, and surgery. Let's talk about the complications of chemotherapy. Chemotherapy comes with a long list of complications and adverse effects, including failure to treat the cancer, stunted growth and development in children, infections due to immunosuppression, including neutropenic sepsis, neurotoxicity, damaging the brain and the nerves, infertility, secondary malignancy, where cancer develops as a consequence of chemotherapy, cardiotoxicity, where it damages the heart, and tumor lysis syndrome. So finally, let's talk in more detail about tumor lysis syndrome. Tumor lysis syndrome results from chemicals released when cells are destroyed by chemotherapy, resulting in high uric acid, high potassium or hyperkalemia, high phosphate, and low calcium, which results from the high phosphate. Uric acid can form crystals in the interstitial space and tubules of the kidneys, resulting in an acute kidney injury. Hyperkalemia can cause cardiac arrhythmias or heart arrhythmias. The release of cytokines can cause systemic inflammation. Very good hydration and very good urine output before chemotherapy is required in patients at risk of tumor lysis syndrome. Allopurinol or rasburicase may be used to suppress the uric acid levels in tumor lysis syndrome. Chapter 86: Lymphoma. Lymphoma is a type of cancer affecting the lymphocytes inside the lymphatic system. Cancerous cells proliferate inside the lymph nodes, causing the lymph nodes to become abnormally large, which is referred to as lymphadenopathy. The many types of lymphoma fall into two categories: Hodgkin's lymphoma, which is a specific disease, and non-Hodgkin's lymphoma, which includes all the other types of lymphoma. Let's start by talking about Hodgkin's lymphoma. Hodgkin's lymphoma is the most common specific type of lymphoma. It has a bimodal age distribution, with peaks around 20 to 25 years of age and around 80 years of age. Risk factors for Hodgkin's lymphoma include HIV infection, the Epstein-Barr virus, autoimmune conditions such as rheumatoid arthritis and sarcoidosis, and a family history of Hodgkin's lymphoma. Next, let's talk about non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma includes many types. A few notable ones are diffuse large B-cell lymphoma, which typically presents as a rapidly growing painless mass in older patients; Burkitt lymphoma, which particularly is associated with the Epstein-Barr virus and HIV; Malt lymphoma, which affects the mucosa-associated lymphoid tissue, usually around the stomach; and Waldenstrom's macroglobulinemia, which affects B lymphocytes with excessive production of immunoglobulin M, or IgM. Risk factors for non-Hodgkin's lymphoma include HIV, the Epstein-Barr virus, Helicobacter pylori or H. pylori infection is associated with Malt lymphoma, hepatitis B or C infection, exposure to pesticides, exposure to trichloroethylene, which is a chemical with a variety of industrial uses, and a family history of lymphoma. Next, let's talk about the presentation. Lymphadenopathy is the key presenting symptom. The enlarged abnormal lymph node or multiple lymph nodes might be in the neck, the axilla or armpit, or the inguinal region in the groin. They are characteristically non-tender and they feel firm or rubbery. Patients with Hodgkin's lymphoma may experience lymph node pain after drinking alcohol. B symptoms refer to the systemic symptoms of lymphoma, including fever, weight loss, and night sweats. Additional non-specific symptoms can include fatigue, itching, cough, shortness of breath, abdominal pain, and recurrent infections. Let's talk about the investigations. Lymph node biopsy is a critical diagnostic investigation for lymphoma. Reed-Sternberg cells are the characteristic finding from a biopsy in Hodgkin's lymphoma. Reed-Sternberg cells are large cancerous B lymphocytes that have two nuclei, and each nuclei has a prominent nucleoli, and this gives them a cartoonish appearance of an owl face with large eyes. CT, MRI, and PET scans can be used to help with the diagnosis and staging of the disease. Let's talk about the Lugano classification. The Lugano classification system is used for Hodgkin's and non-Hodgkin's lymphoma, and it replaces the older Ann Arbor system. The Lugano classification emphasizes whether the affected nodes are above or below the diaphragm. A simplified version is Stage 1, where the lymphoma is confined to one node or group of nodes. Stage 2, where the lymphoma is in more than one group of nodes, but on the same side of the diaphragm, either above or below. Stage 3 is where the lymphoma affects lymph nodes both above and below the diaphragm. And stage 4 is when there's widespread involvement, including non-lymphatic organs, such as the lungs or the liver. Finally, let's talk about management. The critical treatments for Hodgkin's lymphoma are chemotherapy and radiotherapy. Treatment aims to cure the disease, and it's usually successful. However, there is a risk of relapse, and there's the side effects from the treatment. Chemotherapy may result in infections, cognitive impairment, secondary cancers, for example leukemia, and infertility. Radiotherapy creates a risk of tissue fibrosis, secondary cancers, and infertility. Management of non-Hodgkin's lymphoma depends on the type and the stage of the cancer, and it may involve watchful waiting, chemotherapy, monoclonal antibodies, for example rituximab, which targets B cells, radiotherapy, and stem cell transplantation. Chapter 87: Myeloma. Myeloma is a type of cancer affecting the plasma cells in the bone marrow. Plasma cells are B lymphocytes, or B cells, that produce antibodies. Cancer in a specific type of plasma cell results in production of large quantities of a specific paraprotein, or M protein, which is an abnormal antibody or part of an antibody. Multiple myeloma is where the myeloma affects multiple bone marrow areas in the body. Monoclonal gammopathy of undetermined significance, or MGUS, involves the production of a specific paraprotein without other features of myeloma or cancer. Monoclonal refers to identical copies or clones originating from a single cell. MGUS is often an incidental finding in an otherwise healthy person. It has a small risk of progression to myeloma of about 1% per year. Smoldering myeloma involves abnormal plasma cells and paraproteins, but no organ damage or symptoms. It has a greater risk of progression to myeloma compared with MGUS of around 10% per year. So let's talk in more detail about the pathophysiology. Plasma cells are B lymphocytes, or B cells, of the immune system that have developed to produce a specific antibody. Antibodies are also called immunoglobulins. Antibodies are complex molecules made up of heavy chains and light chains arranged in a Y shape. They help the immune system recognize and fight infections by targeting specific proteins on the pathogen. The 5 types of antibodies are A, G, M, D, and E. Myeloma is cancer of a single type of plasma cell with a genetic mutation that causes them to rapidly and uncontrollably multiply. They produce a specific paraprotein, also called an M protein, which is an abnormal antibody or immunoglobulin, or part of an antibody, often the light chain part of the antibody. There is an abnormally high level of this paraprotein, which is called paraproteinemia. The Bence-Jones protein refers to free light chains in the urine. Let's go through the 4 features. The CRAB mnemonic can be used to remember the 4 key features of myeloma. C for calcium, which is elevated, R for renal failure, A for anemia, and B for bone lesions and bone pain. So let's talk about anemia. Anemia is the most common complication of myeloma. The cancerous plasma cells invade the bone marrow, which is called bone marrow infiltration, resulting in suppression of the other cell lines, which leads to anemia, or a low hemoglobin, leukopenia, which is a low white blood cell count, and thrombocytopenia, which are low platelets. Anemia in myeloma tends to be normocytic, with a normal size, and normochromic, with a normal color to the red blood cells. Next, let's talk about myeloma bone disease. Myeloma bone disease results from increased osteoclast activity and suppressed osteoblast activity. Osteoclasts absorb the bone and osteoblasts deposit bone. The metabolism of bone becomes imbalanced, with more bone being reabsorbed than bone being constructed. This is caused by cytokines released from the abnormal plasma cells and from nearby cells. Common sites of myeloma bone disease are the skull, spine, long bones, and ribs. The abnormal bone metabolism is patchy, meaning that the bone becomes very thin in some areas while other areas remain relatively normal. These patches of thin bone are described as osteolytic lesions. These weak points in the bone lead to pathological fractures. For example, a vertebral body in the spine may collapse, which is called a vertebral fracture, or a long bone such as the femur may break under minimal force. Increased osteoclast activity causes calcium reabsorption from the bone into the blood, and this results in hypercalcemia, or a raised calcium level. Plasmacytomas are individual tumors formed by cancerous plasma cells. These can occur in the bones, replacing normal bone tissue, or in the soft tissues. Next, let's talk about renal disease. Patients with myeloma often develop renal impairment, which can have various causes, including paraproteins deposited in the kidneys, hypercalcemia or a raised calcium level in the blood affecting kidney function, dehydration, glomerulonephritis, which is inflammation around the glomerulus and the nephron, and the medications used to treat the condition. Next, let's talk about hyperviscosity syndrome. The normal plasma viscosity, or the internal friction in blood flow, is between 1.3 and 1.7 times that of water. An oversimplified description is that blood is 1.3 to 1.7 times thicker than water. Plasma viscosity increases when more proteins are in the blood, such as the paraproteins found in myeloma. Therefore, myeloma increases the plasma viscosity, or the internal friction in blood flow. Hyperviscosity syndrome is considered an emergency. It can cause many issues including bleeding, for example nosebleeds and bleeding gums, visual symptoms and eye changes, for example retinal hemorrhages, neurological complications, for example stroke, and heart failure. Let's go through the risk factors for myeloma. The risk factors are older age, being male, Black ethnic origin, family history, and obesity. Next, let's talk about the presentation. The presenting features that should raise suspicion of myeloma include persistent bone pain, for example spinal pain, pathological fractures, unexplained fatigue, unexplained weight loss, fever of unknown origin, hypercalcemia or raised calcium found on the blood test, anemia, or renal impairment, not explained by other causes. Next, let's talk about the investigations. The information here is simplified from the NICE Clinical Knowledge Summaries updated in 2022 and the NICE Guidelines updated in 2018 on myeloma. Laboratory investigations include a full blood count to look for anemia or leukopenia or a low white cell count, a calcium level which is raised in myeloma, an ESR or erythrocyte sedimentation rate which is increased in myeloma, plasma viscosity which is increased in myeloma, a renal profile blood test or Usinase for renal impairment, a serum protein electrophoresis to detect the paraproteinemia or high levels of the paraprotein, a serum-free light chain assay, which can be used to detect the abnormally abundant light chains in the blood, and a urine protein electrophoresis to detect the Bence-Jones protein. A bone marrow biopsy is required to confirm the diagnosis and perform cytogenetic testing. Imaging is used to assess for bone lesions. The order of preference for looking for bone lesions is a whole-body MRI scan, a whole-body low-dose CT scan, and the final choice is a skeletal survey, which involves X-ray images of the entire skeleton. Let's talk about the X-ray findings. Typical X-ray changes seen in patients with myeloma include well-defined lytic lesions, which are described as looking punched out from the bone, diffuse osteopenia, which is reduced density of the bone, and abnormal fractures. A raindrop skull, sometimes called a pepper pot skull, refers to multiple lytic lesions seen in the skull on an X-ray in certain patients with myeloma. Next, let's talk about management. An oncology and hematology multidisciplinary team will coordinate treatment. Treatment aims to control the disease, and it tends to take a relapsing remitting course and is never fully cured. Treatment usually involves a combination of chemotherapy, which may include bortezomib, which is a proteasome inhibitor, thalidomide, and dexamethasone. High-dose chemotherapy followed by a stem cell transplant is an option for fitter patients and may achieve a more extended period of remission. Stem cell transplantation can be autologous, which is using the person's own stem cells, or allogeneic, which involves using stem cells from a healthy donor. Management of myeloma bone disease may involve bisphosphonates to suppress the osteoclast activity. Radiotherapy for bone lesions can improve the bone pain. Orthopedic surgery to stabilize the bones, for example, inserting a prophylactic intramedullary rod into the center of the bone, or orthopedic surgery may be used to treat fractures. And cement augmentation, which involves injecting cement into the vertebral fractures or lesions to improve spine stability and pain. Finally, let's go through the complications. There are many complications to myeloma and its treatment, including infections, bone pain, fractures, renal failure, anemia, hypercalcemia or the raised calcium, peripheral neuropathy, spinal cord compression, hyperviscosity syndrome, and venous thromboembolism. Chapter 88: Myeloproliferative Disorders. Myeloproliferative disorders involve uncontrolled proliferation of a single type of stem cell. They're considered a form of cancer occurring in the bone marrow, although they tend to develop and progress slowly. They have the potential to transform into acute myeloid leukemia. The myeloproliferative disorders to remember are primary myelofibrosis, polycythemia vera, and essential thrombocythemia. For primary myelofibrosis, the proliferating cell line is the hematopoietic stem cells, and the blood findings are low hemoglobin, a high or low white blood cell count, and a high or low platelet count. For polycythemia vera, the proliferating cell line is the erythroid cells, and the blood finding is a high or raised hemoglobin. For essential thrombocythemia, The proliferating cell line is the megakaryocyte line, and the blood finding is a high platelet count. These conditions are associated with mutations in certain genes: the JAK2 gene, the MPL gene, and the CALR gene. A Tom tip for you: the mutation to remember is JAK2. Treatment might involve JAK2 inhibitors such as ruxolitinib. So let's talk in more detail about myelofibrosis. Myelofibrosis can result from primary myelofibrosis, polycythemia vera, or essential thrombocythemia. Myelofibrosis is where the proliferating cell line leads to bone marrow fibrosis, where the bone marrow is replaced by scar tissue. This is in response to cytokines released from the proliferating cells. One particular cytokine is fibroblast growth factor. Fibrosis affects the production of blood cells and can lead to a low hemoglobin or anemia, low white blood cells or leukopenia, and low platelets or thrombocytopenia. When the bone marrow is replaced by scar tissue, the production of blood cells, or hematopoiesis, starts to happen in other areas, and this is known as extramedullary hematopoiesis. Production of blood cells in the liver and the spleen causes hepatomegaly, or a large liver, splenomegaly, or a large spleen, and portal hypertension, or raised blood pressure in the portal system. When it occurs around the spine, it can cause spinal cord compression. A blood film in myelofibrosis can show teardrop-shaped red blood cells, anisocytosis, which is varying sizes of the red blood cells, and blasts, which are immature red or white blood cells. Let's talk about the presentation. Initially, myeloproliferative disorders may be asymptomatic or have no symptoms. They can present with non-specific symptoms of fatigue, weight loss, night sweats, and fever. There may be signs and symptoms of underlying complications, such as anemia, where there'll be tiredness, shortness of breath, and dizziness, splenomegaly, which may present with abdominal pain, portal hypertension may present with ascites, varices, and abdominal pain. Low platelets may present with bleeding and petechiae, or non-blanching lesions under the skin. Raised hemoglobin might present with itching, headaches, and a red face. Low white blood cells can present with infections, and gout can be a complication of polycythemia. Thrombosis, or blood clots, is a common complication of polycythemia and thrombocythemia, or a raised platelet count, leading to myocardial infarction, stroke, or venous thromboembolism, for example DVTs and PEs. Clinical signs of polycythemia or raised hemoglobin include a ruddy complexion or a red face, conjunctival plethora, which is the opposite of conjunctival pallor, so under the eyelid it's particularly red, splenomegaly, and hypertension. Next, let's talk about the diagnosis. A bone marrow biopsy is required to confirm the diagnosis. Bone marrow aspiration may be dry with myelofibrosis, as the bone marrow has turned to scar tissue. That means when you're trying to aspirate fluid from the bone marrow, there's no fluid there. Testing for the JAK2, MPL, and CALR genes can help with diagnosis and management. Finally, let's talk about management. Management of primary myelofibrosis may involve no active treatment for mild disease with minimal symptoms, supportive management of complications such as anemia, splenomegaly, and portal hypertension, chemotherapy, for example hydroxycarbamide, to help control the disease, targeted therapies such as JAK2 inhibitors, such as ruxolitinib, and allogeneic stem cell transplantation, which is risky but potentially curative. Management of polycythemia vera may involve venesection, which involves regularly taking some of the blood away to keep the hemoglobin in the normal range, aspirin to reduce the risk of thrombus formation, and chemotherapy, typically hydroxycarbamide, to help control the disease. Management of essential thrombocythemia may involve aspirin to reduce the risk of thrombus formation, chemotherapy, typically with hydroxycarbamide, to help control the disease, and anagrelide, which is a specialist platelet-lowering agent. Chapter 89. Myelodysplastic Syndrome. Myelodysplastic syndrome is a form of cancer caused by a mutation in the myeloid cells in the bone marrow, resulting in inadequate production of blood cells, which is described as ineffective hematopoiesis. There are various types of myelodysplastic syndrome. It has the potential to transform into acute myeloid leukemia. Myelodysplastic syndrome causes low levels of blood components that originate from the myeloid cell line, specifically anemia, which is a low hemoglobin, neutropenia, or a low neutrophil count, and thrombocytopenia, which is a low platelet count. Pancytopenia is a combination of low red blood cells, low white blood cells, and low platelets. The key risk factors for myelodysplastic syndrome are older age and previous chemotherapy or radiotherapy. So let's talk about the presentation. Patients with myelodysplastic syndrome may be asymptomatic, and the condition is picked up or diagnosed after incidental findings on a full blood count. They may present with symptoms of anemia, such as fatigue, pale skin or pallor, or shortness of breath, neutropenia with frequent or severe infections, and thrombocytopenia with bleeding and purpura, or bleeding under the skin causing non-blanching lesions. Let's talk about making the diagnosis. The full blood count results will be abnormal. There may be blast cells or blasts on the blood film, and these are immature red or white blood cells. A bone marrow biopsy is required to confirm the diagnosis. Finally, let's talk about management. Depending on the symptoms, the risk of progression, and the overall prognosis, the treatment options are watchful waiting, simply monitoring and no active treatment, supportive treatment, for example, blood or platelet transfusions, erythropoietin, which stimulates red blood cell production, granulocyte colony stimulating factor, which stimulates neutrophil production, chemotherapy and targeted therapies, for example, lenalidomide, and allogeneic stem cell transplantation, which is risky but potentially curative. Chapter 90. Thrombocytopenia. Thrombocytopenia describes a low platelet count. The normal platelet count is 150 to 450 times 10 to the power of 9 per litre. There's a long list of causes of a low platelet count, and these can be split into problems with production of platelets and problems with destruction of platelets. Reduced platelet production can occur with certain viral infections, for example, the Epstein-Barr virus, cytomegalovirus, and HIV, B12 deficiency, folic acid deficiency or folate deficiency, liver failure, which causes reduced thrombopoietin production by the liver, and thrombopoietin is what stimulates the production of platelets, leukemia, myelodysplastic syndrome, and chemotherapy. Increased platelet destruction can occur with medications, for example, sodium valproate and methotrexate, alcohol, immune thrombocytopenic purpura, or ITP, thrombotic thrombocytopenic purpura, or TTP, heparin-induced thrombocytopenia, or HIT, and hemolytic uremic syndrome, or HUS. Let's talk about the presentation. Mild thrombocytopenia may be asymptomatic and found incidentally on a full blood count. A platelet count below 50 times 10 to the power of 9 per litre will result in easy bruising and prolonged bleeding times. It may present with nosebleeds, bleeding gums, heavy periods or menorrhagia, easy bruising, hematuria or blood in the urine, or rectal bleeding. Platelet counts below 10 times 10 to the power of 9 per litre are at high risk of spontaneous bleeding. Particularly concerning are intracranial bleeding, or bleeding that can affect the brain, and gastrointestinal bleeding, for example, bleeding in the stomach or the bowel. Let's talk about the differential diagnosis for abnormal bleeding. The clotting system creates blood clots to stop bleeding, and there are several ways that this system can malfunction. The top differentials for abnormal or prolonged bleeding to remember are thrombocytopenia, von Willebrand disease, hemophilia A and hemophilia B, and disseminated intravascular coagulation, usually secondary to sepsis. Next, let's talk in more detail about immune thrombocytopenic purpura. Immune thrombocytopenic purpura, or ITP, can also be called autoimmune thrombocytopenic purpura, idiopathic thrombocytopenic purpura, and primary thrombocytopenic purpura. They all refer to the same condition. Immune thrombocytopenic purpura is a condition where antibodies are created against platelets. These antibodies create an immune response against platelets, leading to them breaking down or their destruction and a low platelet count. It characteristically presents with purpura, which are non-blanching lesions caused by bleeding under the skin. Care involves monitoring the platelet count, controlling the blood pressure, and suppressing menstrual periods. Management options include prednisolone or steroids, IV immunoglobulins, thrombopoietin receptor agonists, for example avatrombopag, rituximab, which is a monoclonal antibody that targets B cells, and splenectomy. A tom tip for you: B cells produce antibodies. Rituximab is worth remembering as a monoclonal antibody that targets the CD20 proteins on the surface of B cells. By attacking B cells and reducing their numbers, it reduces the production of antibodies that are responsible for autoimmune disease. Rituximab is used to treat many autoimmune conditions, from rheumatoid arthritis to immune thrombocytopenic purpura. Next, let's talk about thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura, or TTP, is a condition where tiny thrombi, or blood clots, develop throughout the small blood vessels, using up platelets. As the problem is in the small vessels, it's described as a microangiopathy, and this causes thrombocytopenia, or a low platelet count, purpura, which are non-blanching lesions, and tissue ischemia and end organ damage due to the blood clots blocking the blood flow to these areas. The reason for these thrombi developing is due to a problem with a specific protein called ADAMTS13. This protein normally inactivates von Willebrand factor, reduces platelet adhesion to vessel walls, and reduces thrombus formation. Deficiency in the ADAMTS13 protein can be due to an inherited genetic mutation, which means it's hereditary, or autoimmune disease where antibodies are created against the protein. This is where it's acquired during the patient's lifetime. Treatment is guided by a hematologist and may involve plasma exchange, steroids, and rituximab. Finally, let's talk in more detail about heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia, or HIT, involves the development of antibodies against platelets in response to heparin, usually unfractionated heparin, but it can occur with a low molecular weight heparin. Heparin-induced antibodies target a protein on platelets called platelet factor 4, or PF4. The condition typically presents around 5 to 10 days after starting treatment with heparin. HIT antibodies bind to platelets and activate the clotting system, causing a hypercoagulable state and thrombosis, for example, deep vein thrombosis. They also break down platelets and cause thrombocytopenia. Therefore, there is a counterintuitive situation where a patient is on heparin, has a low platelet count, but still develops abnormal blood clots. Diagnosis is by testing for HIT antibodies on a blood sample. Management involves stopping heparin and using an alternative anticoagulant guided by a specialist, for example, fondaparinux or argatroban. Chapter 91: Von Willebrand disease. Von Willebrand disease is the most common inherited cause of abnormal or prolonged bleeding. There are many underlying genetic causes, most of which are autosomal dominant. There is a rarer acquired version of von Willebrand disease, which is usually secondary to an underlying disease, for example, leukemia. In von Willebrand disease, there is a deficiency, absence, or malfunctioning of a glycoprotein called von Willebrand factor. Von Willebrand factor is important in platelet adhesion and aggregation, or platelets sticking together inside damaged vessels. A problem with von Willebrand factor means that platelets don't stick or clump together as well as they should do. There are 3 types of von Willebrand disease. Type 1 involves a partial deficiency of von Willebrand factor and is the most common and the mildest type. Type 2 involves the reduced production of von Willebrand factor, and type 3 involves a complete deficiency of von Willebrand factor, and this is the most rare and the most severe type. Let's talk about the presentation. Patients present with a history of unusually easy, prolonged, or heavy bleeding, for example, bleeding gums after brushing their teeth, nosebleeds or epistaxis, easy bruising, heavy menstrual periods or menorrhagia, and heavy bleeding during and after surgical operations. A family history of heavy bleeding, for example, menorrhagia, or von Willebrand disease is relevant, as it's a genetic condition most of the time. So how is it diagnosed? The diagnosis is based on a history of abnormal bleeding, family history, bleeding assessment tools, and laboratory investigations. Due to the various underlying causes and types, there's no single easy test for von Willebrand disease. Finally, let's talk about management. Von Willebrand disease does not generally require daily treatment. Management is needed in response to significant bleeding or trauma to stop the bleeding, or in preparation for operations to prevent bleeding. Options include desmopressin, which stimulates the release of von Willebrand factor from endothelial cells, tranexamic acid, an infusion of von Willebrand factor, or an infusion of factor VIII plus von Willebrand factor. Options for managing heavy menstrual periods or menorrhagia include tranexamic acid, mefenamic acid, the Mirena coil, the combined oral contraceptive pill, or norethisterone. A hysterectomy or surgical removal of the uterus may be required in severe cases of heavy menstrual bleeding. Chapter 92. Hemophilia. Hemophilia A and hemophilia B are severe inherited bleeding disorders. Hemophilia A is caused by deficiency of factor VIII. Hemophilia B, which is also known as Christmas disease, is caused by a deficiency in factor IX. Let's talk about X-linked recessive genetic inheritance. Hemophilia A and hemophilia B are both X-linked recessive diseases. All X chromosomes need to have the abnormal gene for the patient to have hemophilia. Males only have one X chromosome and require only one abnormal copy for them to have the disease. Females have two X chromosomes, so when one copy is affected, they are asymptomatic carriers of the gene because they still have the other normal X chromosome. Therefore, hemophilia A and hemophilia B primarily affect males. For a female to be affected, they would have to inherit two abnormal X chromosomes. Therefore, they would require an affected father and a mother who is either a carrier or affected herself. Let's talk about the features. Both hemophilia A and B are severe bleeding disorders. Patients can bleed excessively in response to minor trauma, and they're at risk of spontaneous bleeding without any trauma. Most cases present in neonates or early childhood. It presents with intracranial hemorrhage, hematomas, and cord bleeding in neonates. Spontaneous bleeding into joints, which is called hemarthrosis, such as the ankle, knee, or elbow, can lead to joint damage and deformity. Bleeding into the muscles can cause compartment syndrome. Other areas of bleeding include the oral mucosa, or bleeding gums, nosebleeds, or epistaxis, gastrointestinal bleeding, for example bleeding in the stomach, urinary tract bleeding causing hematuria, or blood in the urine, intracranial hemorrhage, or bleeding that can affect the brain, and bleeding from surgical wounds. So how is it diagnosed? Diagnosis is based on bleeding scores, coagulation factor assays, checking the levels of the coagulation factors, and genetic testing. Finally, let's talk about management. The affected clotting factors, 8 in hemophilia A and 9 in hemophilia B, can be given by intravenous infusion, either regularly or in response to bleeding. A complication of this treatment is the formation of antibodies called inhibitors against the treatment, resulting in it becoming ineffective. Chapter 93. Deep vein thrombosis and venous thromboembolism. Venous thromboembolism, or VTE, is a common and potentially fatal condition. It involves a blood clot, or thrombus, developing in the circulation, usually secondary to blood stagnation or hypercoagulable states. When a thrombus develops in a deep vein, it's called a deep vein thrombosis, or DVT. Once a thrombus has developed, it can travel, or embolize, from the deep veins through the right side of the heart and into the lungs, where it becomes lodged in the pulmonary arteries. This blocks blood flow to areas of the lungs distal to the blood clot and is called a pulmonary embolism, or PE. If a patient has a septal defect in their heart, for example an atrial septal defect, that is a hole between the left and right hand side of the heart, the thrombus can pass through to the left side of the heart and into the systemic circulation. If it travels to the brain, it can cause a large stroke. Let's go through the risk factors. The risk factors for venous thromboembolism are immobility, recent surgery, long-haul travel, for example, aeroplane trips to the other side of the world, pregnancy, hormone therapy with estrogen, for example, the combined contraceptive pill or hormone replacement therapy, malignancy or cancer, polycythemia, systemic lupus erythematosus, and thrombophilia. A tom tip: in your exams, when a patient presents with possible features of a deep vein thrombosis or a pulmonary embolism, ask about risk factors such as periods of immobility, surgery, and long-haul flights, and this will score you extra points. Let's talk about thrombophilias. Thrombophilias are conditions that predispose patients to developing blood clots. There are a large number of these, including antiphospholipid syndrome, factor V Leiden, antithrombin deficiency, protein C or protein S deficiency, hyperhomocystinemia, prothrombin gene variant, and activated protein C resistance. A tom tip for you: the cause of venous thromboembolism to remember is antiphospholipid syndrome, which is associated with recurrent miscarriage and diagnosed with a blood test for antiphospholipid antibodies. Let's talk about venous thromboembolism prophylaxis. Every patient admitted to hospital is assessed for their risk of venous thromboembolism. Patients at increased risk receive prophylaxis unless it's contraindicated. Prophylaxis usually involves low molecular weight heparin, such as enoxaparin. Contraindications include active bleeding or existing anticoagulation with warfarin or a DOAC. Antiembolic compression stockings are also used to reduce the risk of deep vein thrombosis. Peripheral arterial disease is the main contraindication for compression stockings. Let's move on to the presentation of deep vein thrombosis. DVTs are almost always unilateral. If the symptoms are bilateral, it's probably due to an alternative diagnosis, such as chronic venous insufficiency or heart failure. DVTs can present with calf or leg swelling, dilated superficial veins, tenderness to the calf, particularly over the site of the deep veins, edema or swelling, and color changes to the leg. The calf circumference is measured 10 centimeters below the tibial tuberosity. More than a 3 centimeter difference between the legs is significant. Consider a pulmonary embolism, for example, asking about shortness of breath and chest pain in patients who have features of a deep vein thrombosis. Next, let's talk about the Wells score. The Wells score predicts the risk of a patient presenting with symptoms having a deep vein thrombosis or a pulmonary embolism. The scoring system includes risk factors, for example, recent surgery, and clinical findings, for example, unilateral calf swelling more than 3 centimeters greater than the other leg. Next, let's talk about making the diagnosis. The Wells score is used when considering a diagnosis of a deep vein thrombosis. The outcome decides the next steps. If the Wells score determines that a deep vein thrombosis is likely, the next step is to perform a leg vein ultrasound scan. If the Wells score says that a DVT is unlikely, the next step is to perform a D-dimer test, and if this is positive, then go on to perform a leg vein ultrasound. D-dimer is a blood test for venous thromboembolism. It's sensitive at around 95% sensitivity, but not specific. It helps to exclude venous thromboembolism where there's a low suspicion. It's almost always raised if there is a DVT or a PE. However, there are many other conditions that can cause a raised D-dimer, for example, pneumonia, malignancy or cancer, heart failure, surgery, and pregnancy. Ultrasound of the leg is required to diagnose a deep vein thrombosis. The NICE guidelines recommend repeating a negative ultrasound scan after 6 to 8 days if the patient has a positive D-dimer and the Wells score suggests a DVT is likely. CT pulmonary angiogram, or CTPA, is the usual first-line imaging investigation for a pulmonary embolism. Let's talk about the initial management. In most cases, the NICE guidelines from 2020 recommend treatment dose apixaban or rivaroxaban as the initial anticoagulant. Low molecular weight heparin is the main alternative. Anticoagulation should be started immediately in patients where a DVT or PE is suspected and there's going to be a delay in getting the scan to confirm the diagnosis. The NICE guidelines from 2020 recommend considering catheter-directed thrombolysis in patients with a symptomatic iliofemoral DVT and symptoms lasting less than 14 days. This involves a catheter inserted under X-ray guidance through the venous system to apply thrombolysis directly into the clot. Next, let's talk about long-term anticoagulation. The options for long-term anticoagulation in venous thromboembolism are a DOAC, warfarin, or low molecular weight heparin. Direct-acting oral anticoagulants, or DOACs, are oral anticoagulants that do not require monitoring. Options are apixaban, rivaroxaban, edoxaban, and dabigatran. DOACs are suitable for most patients. Exceptions include severe renal impairment, for example, creatinine clearance of less than 15 milliliters per minute, patients with antiphospholipid syndrome, and patients who are pregnant. Warfarin is a vitamin K antagonist. The target INR for warfarin is between 2 and 3 when treating DVTs and PEs. It's first line in patients with antiphospholipid syndrome, who require initial concurrent treatment with low molecular weight heparin. Low molecular weight heparin is the first-line anticoagulant in pregnancy. Anticoagulation is continued for 3 months if there's a reversible cause, and then it's reviewed, 3 to 6 months in active cancer, and then it's reviewed, or long-term for unprovoked venous thromboembolism, recurrent venous thromboembolism, or where there's an irreversible underlying cause, for example, thrombophilia. Let's talk about inferior vena cava filters. Inferior vena cava filters are devices that are inserted into the inferior vena cava, and they're designed to filter the blood and catch any blood clots that are traveling from the venous system towards the heart and the lungs. They act as a sieve, allowing the blood to flow through while stopping and collecting larger blood clots. They're used in patients who are unsuitable for anticoagulation or where a pulmonary embolism has occurred whilst already being on anticoagulation. Next, let's talk about investigating an unprovoked deep vein thrombosis. When patients have their first episode of venous thromboembolism without a clear cause, the NICE guidelines from 2020 recommend reviewing the medical history, baseline blood results, and physical examination for evidence of cancer. In patients with an unprovoked DVT or PE that are not going to continue anticoagulation beyond 3 to 6 months, the NICE guidelines recommend considering testing for antiphospholipid syndrome by checking for antiphospholipid antibodies and hereditary thrombophilias only if they have a first-degree relative also affected by a DVT or PE. Finally, let's talk about Budd-Chiari syndrome. Budd-Chiari syndrome involves obstruction to the outflow of blood from the liver caused by thrombosis in the hepatic veins or the inferior vena cava. Budd-Chiari syndrome is associated with hypercoagulable states, for example, myeloproliferative disorders. It presents with a classic triad of abdominal pain, hepatomegaly, and ascites. Doppler ultrasonography is the usual imaging investigation for establishing the diagnosis of Budd-Chiari syndrome. Treatment options include anticoagulation, for example low molecular weight heparin and warfarin, endovascular procedures, for example thrombolysis or angioplasty, transjugular intrahepatic portosystemic shunt or TIPS procedure, and liver transplant. Chapter 94: Osteoarthritis. Osteoarthritis is often described as wear and tear in the joints. It occurs in the synovial joints and results from genetic factors, overuse, and injury. Osteoarthritis is thought to result from an imbalance between cartilage damage and the chondrocyte response, leading to structural issues in the joint. Risk factors include obesity, age, occupation, trauma to the joint, being female, and family history. Let's go through the commonly affected joints. These are the hips, knees, distal interphalangeal or DIP joints in the hands, carpometacarpal or CMC joint at the base of the thumb, the lumbar spine at the lower back, and the cervical spine in the neck, which is described as cervical spondylosis. Next, let's talk about the X-ray changes. The 4 key X-ray changes in osteoarthritis can be remembered with the LOSS mnemonic. L for loss of joint space, O for osteophytes, which are bone spurs, S for subarticular sclerosis, which is increased density of the bone along the joint line, and S for subchondral cysts, which are fluid-filled holes in the bone. X-ray reports might describe findings of osteoarthritis as degenerative changes. X-ray changes do not necessarily correlate with symptoms, and a patient might have significant signs on an X-ray but minimal symptoms, or the reverse, having severe symptoms with minimal signs on the X-ray. Let's talk about the presentation. Osteoarthritis presents with joint pain and stiffness. The pain and stiffness tend to worsen with activity and at the end of the day. This is the reverse of the pattern seen in inflammatory arthritis, where symptoms are worse in the morning and improve with activity. Osteoarthritis leads to deformity, instability, and reduced function of the joint. A Tom tip for you: patients may present with referred pain, particularly in the adjacent joints. For example, consider osteoarthritis in the hip in patients presenting with lower back pain or knee pain. General signs of osteoarthritis are bulky, bony enlargement of the joint, restricted range of motion, crepitus or a crunching feeling on movement of the joint, and effusions or fluid around the joint. Let's talk about the signs in the hands. Heberdin's nodes occur in the distal interphalangeal joints of the fingers, the furthest joint of the finger, and these are lumps or nodules at the ends of the fingers in the joints. Bouchard's nodes occur in the proximal interphalangeal joints, or PIP joints. Other signs are squaring at the base of the thumb in the carpometacarpal joint, a weak grip, and reduced range of motion throughout the joints of the hands. The carpometacarpal joint at the base of the thumb is a saddle joint with the metacarpal bone sitting on the trapezius bone, using it like a saddle. It gets a lot of use and is very prone to wear and tear, making it a key site of osteoarthritis. Next, let's talk about making the diagnosis. The NICE guidelines from 2022 suggest a diagnosis can be made without investigations if the patient is over 45 and has typical pain associated with activity and no morning stiffness, or stiffness that lasts less than 30 minutes. Next, let's talk about management. Non-pharmacological management involves patient education and lifestyle changes, such as therapeutic exercise to improve strength and function and reduce pain, weight loss if they're overweight to reduce the load on the joint, and occupational therapy to support activities and function, for example, walking aids and adaptations to the home. Pharmacological management recommended by the NICE guidelines are topical NSAIDs or non-steroidal anti-inflammatory drugs, first line for knee osteoarthritis, or oral NSAIDs where required and suitable, co-prescribed with a proton pump inhibitor for gastroprotection. Weak opiates and paracetamol are only recommended for short-term, infrequent use. The NICE guidelines from 2022 recommend against using strong opiates for osteoarthritis. Intra-articular steroid injections may temporarily improve symptoms, and the NICE guidelines say that they may have an effect up to 10 weeks of duration. Joint replacement may be used in severe cases. The hips and the knees are the most commonly replaced joints. Finally, some medication notes. Non-steroidal anti-inflammatory drugs, for example ibuprofen or naproxen, are very effective for musculoskeletal pain. However, they must be used cautiously, particularly in older patients and with patients on anticoagulants such as aspirin or DOACs. They're best used intermittently, only for a short time during flare-ups. They have several potential adverse effects, including gastrointestinal side effects such as gastritis and peptic ulcers, which can lead to upper gastrointestinal bleeding, renal side effects such as acute kidney injury, for example acute tubular necrosis, and chronic kidney disease, cardiovascular side effects such as hypertension, heart failure, myocardial infarction, and stroke, and they may exacerbate symptoms of asthma. There's little evidence that opiates help with chronic pain. They're associated with side effects, risks, tolerance, dependence, and withdrawal. The use of opiates long-term for chronic pain often results in dependence without any objective benefits. So patients may say, I can't stop taking the opiates or I'll get withdrawal side effects, but I don't actually benefit in terms of my pain control. A Tom tip for you, the World Health Organization pain ladder is not helpful in chronic pain. Paracetamol and opiates are not recommended for regular use in osteoarthritis. Remember that NSAIDs cause hypertension by blocking prostaglandins. Remember that prostaglandins cause vasodilation, or expansion of the blood vessels, and so NSAIDs should be used very cautiously in patients with a history of high blood pressure. Chapter 95. Rheumatoid arthritis. Rheumatoid arthritis is an autoimmune condition that causes chronic inflammation in the synovial lining of the joints, tendon sheaths, and bursa. It's a type of inflammatory arthritis. Synovial inflammation is called synovitis. Inflammation of the tendons increases the risk of tendon rupture. Rheumatoid arthritis tends to affect multiple small joints symmetrically across both sides of the body. This pattern is described as symmetrical polyarthritis. Rheumatoid arthritis is around 2 to 3 times more common in women than in men. It most often develops in middle age, but it can present at any age. Smoking and obesity are risk factors. A family history increases the risk of rheumatoid arthritis, although there's no clear inheritance pattern. The most common gene associated with rheumatoid arthritis is HLA-DR4. The disease course varies between patients, from mild and remitting to severe and progressive. Disease activity, positive antibodies, and erosions on an X-ray predict worse disease. Let's talk about antibodies. Rheumatoid factor is an autoantibody present in around 70% of patients with rheumatoid arthritis. Rheumatoid factor targets the Fc portion of the immunoglobulin G. All antibodies or immunoglobulins have an Fc portion that interacts with other parts of the immune system. Rheumatoid factor causes immune system activation against the patient's own immunoglobulin G, resulting in systemic inflammation. Rheumatoid factor is most often immunoglobulin type M, or IgM, but it can be other types of immunoglobulin. Anti-cyclic citrullinated peptide antibodies, or anti-CCP antibodies, are more sensitive and specific for rheumatoid arthritis compared with rheumatoid factor. Anti-CCP antibodies are positive in around 80% of patients with rheumatoid arthritis. They often predate the development of rheumatoid arthritis and indicate that a patient will develop the condition at some point. Let's talk about the presentation. The speed of onset can vary from rapid, for example overnight, to gradual, for example over the course of months. The three joint symptoms are pain, stiffness, and swelling. Rheumatoid arthritis typically causes symmetrical distal polyarthritis affecting the small joints of the hands and the feet. The most commonly affected joints are the metacarpophalangeal or MCP joints, the proximal interphalangeal or PIP joints, the wrist, and the metatarsophalangeal or MTP joints in the foot. On palpation of the joints, there will be tenderness and synovial thickening, giving the joints a boggy feeling. A tom tip for you, rheumatoid arthritis very rarely affects the distal interphalangeal joints. Enlarged and painful distal interphalangeal joints are more likely to represent Heberden's nodes due to osteoarthritis. Large joints such as the ankle, knee, hips, and shoulders can also be affected. It can affect the cervical spine in the neck, but not the lumbar spine in the lower back. So lower back pain is unlikely to be related to rheumatoid arthritis. Associated systemic symptoms include fatigue, weight loss, a flu-like illness, and muscle aches and muscle weakness. A tom tip for you, inflammatory arthritis symptoms are worse with rest and improve with activity. They are worst in the morning. Symptoms of mechanical problems, for example osteoarthritis, are worst with activity and improve with rest, and they're worst at the end of the day. Next, let's talk about palindromic rheumatism. Palindromic rheumatism involves self-limiting episodes of inflammatory arthritis with pain, stiffness, and swelling typically affecting only a few joints. The symptoms last days, then they completely resolve. Joints appear normal between episodes. Rheumatoid factor or anti-CCP antibodies may indicate that it will progress to full rheumatoid arthritis. Next, let's talk about hand signs in advanced disease. In patients with advanced rheumatoid arthritis, the hand signs include a Z-shaped deformity to the thumb, a swan neck deformity with hyperextended proximal interphalangeal joints and flexed distal interphalangeal joints, a boutonniere deformity, which involves hyperextended distal interphalangeal joints and flexed proximal interphalangeal joints, and an ulnar deviation of the fingers at the MCP joints, or the metacarpophalangeal joints. Boutonniere deformity is caused by a tear in the central slip of the extensor components at the proximal interphalangeal joint, or PIP joint. The central slip connects to the middle phalanx at the proximal interphalangeal joint, and the lateral bands go around the proximal interphalangeal joint and connect to the distal phalanx. If there's a tear in the central slip, when the patient tries to straighten their finger, the lateral bands pull on the distal phalanx, causing the distal interphalangeal joint to hyperextend and the proximal interphalangeal joint to flex. A swan neck deformity is the opposite of Boutonniere's deformity. It's caused by an extensor mechanism imbalance causing flexion of the DIP joint and extension of the PIP joint. A Tom tip for you: effective treatments mean it's unusual for rheumatoid arthritis to get to the stage of having severe hand signs. However, it's worth becoming familiar with these examination findings as they make great patients for OSCEs. Next, let's talk about atlantoaxial subluxation. Atlantoaxial subluxation occurs in the cervical spine in the neck. Synovitis and damage to the ligaments around the odontoid peg of the axis, or C2, allows it to shift within the atlas, or C1 vertebra. Subluxation can cause spinal cord compression, and this is an emergency. This needs to be considered when a patient is having a general anesthetic and requires intubation. MRI scans can be used to visualize changes in these areas as part of the pre-operative assessment. Next, let's talk about the extra-articular manifestations. There are many extra-articular manifestations of rheumatoid arthritis, and these include pulmonary fibrosis, Veltes syndrome, which is a triad of rheumatoid arthritis, neutropenia, and splenomegaly, Sjogren's syndrome, with dry eyes and a dry mouth, anemia of chronic disease, cardiovascular disease, eye manifestations, rheumatoid nodules, which are firm, painless lumps under the skin, typically on the elbows and the fingers, lymphadenopathy with enlarged abnormal lymph nodes, carpal tunnel syndrome, amyloidosis, bronchiectasis, bronchiolitis obliterans, which is where there's small airway destruction and airflow obstruction in the lungs, and Kaplan syndrome, which involves pulmonary nodules in patients with rheumatoid arthritis that are exposed to coal, silica, or asbestos dust. Eye manifestations related to rheumatoid arthritis and its treatment include dry eye syndrome, which is also called keratoconjunctivitis sicca, episcleritis, scleritis, keratitis, cataracts secondary to steroid treatment, and retinopathy, which can occur secondary to hydroxychloroquine treatment. Next, let's talk about making the diagnosis. The NICE clinical knowledge summaries updated in 2020 recommend an urgent rheumatology referral for patients with persistent synovitis to be seen within 3 weeks. They suggest considering nonsteroidal anti-inflammatory drugs and baseline blood tests whilst awaiting specialist assessment. The investigations that help in the initial assessment are rheumatoid factor, anti-CCP antibodies, inflammatory markers such as C-reactive protein or CRP, and erythrocyte sedimentation rate or ESR, X-rays of the hands and feet for bone changes, and an ultrasound or MRI can be used to detect synovitis, which is useful when clinical findings are unclear. The diagnosis is based on clinical findings and blood results. The American College of Rheumatology / European League Against Rheumatism classification criteria from 2010 can be used to make the diagnosis. Let's go through the X-ray changes. The key X-ray changes are periarticular osteopenia, with thinning of the bones around the joint, bony erosions, soft tissue swelling, and joint destruction and deformity in more advanced disease. Next, let's talk about the scoring systems. The Health Assessment Questionnaire, or HAQ, measures functional ability. The NICE guidelines updated in 2020 recommend a baseline HAQ score at diagnosis, which can then be used to compare to HAQ scores later on to assess the response to treatment. The Disease Activity Score 28 Joints, or DAS28 score, is used in monitoring disease activity and response to treatment, and this involves assessing 28 joints and assigning points for swollen joints, tender points, and also points for ESR and the CRP result. Next, let's talk about management. Treatment involves the multidisciplinary team, which will include rheumatologists, specialist nurses, GPs, physiotherapists, occupational therapists, psychologists, and podiatrists. Starting treatment early improves the outcomes. The aim is to induce remission or get as close to remission as possible. The C-reactive protein and the DAS28 score are used to monitor the success of treatment. Short-term oral or intramuscular steroids may be used at the initial presentation, when initiating a new treatment, and during flares to help settle the inflammation and control the symptoms quickly. Long-term treatment is with conventional disease-modifying anti-rheumatic drugs, or DMARDs, and biologic DMARDs. This might be with monotherapy with methotrexate, leflunomide, or sulfasalazine, combination treatment with multiple DMARDs, or biologic therapies, usually alongside methotrexate. Hydroxychloroquine may be used in mild disease and in palindromic rheumatism. Hydroxychloroquine is considered the mildest DMARD. Other conventional DMARDs include azathioprine, cyclosporin, cyclophosphamide, and mycophenolate. Nonsteroidal anti-inflammatory drugs are helpful for pain relief, but they have associated risks and side effects. Pregnancy can improve symptoms, but some pregnant women experience a symptom flare. Hydroxychloroquine and sulfasalazine are considered the safest DMARDs in pregnancy. Extra folic acid is required when patients are taking sulfasalazine. Methotrexate and leflunomide are very harmful in pregnancy, or teratogenic. Biologic therapies interact with the immune system to reduce inflammation by targeting various aspects of the immune system. Biologic therapies include tumor necrosis factor, or TNF inhibitors, for example adalimumab, infliximab, etanercept, golimumab, and certolizumab. Monoclonal antibodies that target CD20 on B cells, for example rituximab. Anti-interleukin-6 inhibitors, for example sarilumab and tocilizumab. JAK inhibitors, for example upadacitinib, tofacitinib, and baricitinib. And T-cell co-stimulation inhibitors, for example abatacept. Tumor necrosis factor, or TNF, is a cytokine involved in stimulating inflammation, and blocking TNF reduces inflammation. A Tom tip for you: the main biologics to remember are adalimumab, infliximab, and etanercept, which are the TNF inhibitors, and also rituximab, which is a monoclonal antibody that targets the CD20 proteins on the surface of B cells. Biologics cause immunosuppression, increasing the risk of infection certain cancers, for example skin cancer, and reactivation of latent tuberculosis. Orthopedic surgery used to be an important aspect of management when joint deformities developed in rheumatoid arthritis. However, the DMARDs and biologics have dramatically reduced the number of patients that are getting to the stage of needing surgery. Finally, let's go through some notes on medications. Methotrexate interferes with folate metabolism and suppresses the immune system. It's given once a week. Folic acid, 5 mg, is also taken once a week on a different day to the methotrexate. Side effects of methotrexate include mouth ulcers and mucositis, liver toxicity, bone marrow suppression and leukopenia, or a low white blood cell count, and it's highly teratogenic or harmful to pregnancy, and it needs to be avoided before conception in both women and men. Leflunomide is an immunosuppressant medication that interferes with the production of pyrimidine. Pyrimidine is an important component of RNA and DNA. Side effects of leflunomide include mouth ulcers and mucositis, increased blood pressure, liver toxicity, bone marrow suppression and leukopenia, or a low white blood cell count. It's teratogenic, meaning harmful to pregnancy, and it needs to be avoided before conception in both women and men, and peripheral neuropathy. Sulfasalazine is an immunosuppressive and anti-inflammatory medication. The exact mechanism of sulfasalazine is not clear. The side effects include orange urine, reversible male infertility due to a reduced sperm count and quality of sperm, and bone marrow suppression. Hydroxychloroquine is traditionally an anti-malarial medication, and it suppresses the immune system by interfering with toll-like receptors, disrupting antigen presentation, and increasing the pH inside the lysosomes of immune cells. Side effects of hydroxychloroquine include retinal toxicity, specifically macular toxicity, which causes reduced visual acuity, blue-gray skin pigmentation, and hair lightening or bleaching of the hair. A final Tom tip, the unique side effects worth remembering are methotrexate, bone marrow suppression, and leukopenia, and that it's highly teratogenic. Leflunomide causes hypertension and peripheral neuropathy. Sulfasalazine causes orange urine and male infertility. It reduces the sperm count. Hydroxychloroquine causes retinal toxicity, blue-gray skin pigmentation and hair bleaching. Anti-TNF medications cause reactivation of tuberculosis. And rituximab can cause night sweats and thrombocytopenia. Chapter 96. Psoriatic arthritis. Psoriatic arthritis is an inflammatory arthritis associated with psoriasis, the skin condition. It can vary in severity from mild stiffening and soreness in the joints to complete joint destruction in a condition called arthritis mutilans. Psoriatic arthritis occurs in 10 to 20% of patients who have psoriasis, usually within 10 years of developing the skin condition. Arthritis can occur before the skin changes. It's most common in middle age, but it can occur at any age. Psoriatic arthritis is part of the seronegative spondyloarthropathy group of conditions. Other conditions in this group are ankylosing spondylitis and reactive arthritis. It's associated with extra-articular manifestations, meaning problems away from the joints, particularly uveitis, which affects the eyes, and inflammatory bowel disease. Let's talk about the patterns. There are 5 recognized patterns to psoriatic arthritis. Asymmetrical oligoarthritis and symmetrical polyarthritis are the most common. Asymmetrical oligoarthritis affects 1 to 4 joints at any given time, often only on one side of the body. Symmetrical polyarthritis presents similarly to rheumatoid arthritis. More than 4 joints are affected, such as the hands, wrists, and ankles. The third pattern is called distal interphalangeal predominant pattern, which primarily affects the DIP joints or distal interphalangeal joints. However, the DIP joints can be affected across all types of psoriatic arthritis. The fourth type is spondylitis, which presents with back stiffness and pain, and it involves the axial skeleton, which is the spine and the sacroiliac joints. And the final pattern is arthritis mutilans, which is the most severe form of psoriatic arthritis. This affects the phalanges, which are the bones of the fingers and the toes, and there is osteolysis or destruction of the bones around the joints, which leads to progressive shortening of the digits, the fingers or the toes. As the digit shortens, or the finger or the toe gets shorter, the skin folds around that digit, and this gives an appearance which is described as a telescoping digit, as the skin folds downwards as it shortens. A tom tip for you, psoriatic arthritis tends to affect the distal interphalangeal joints and the axial skeleton, whereas rheumatoid arthritis tends not to affect the distal interphalangeal joints and the axial skeleton, and this can help you distinguish between them. Let's talk about the signs. The signs of psoriatic arthritis are plaques of psoriasis on the skin, indicating the skin condition, nail pitting, which are tiny indents in the fingernails and the toenails, onycholysis, which is separation of the nail from the nail bed, dactylitis, which is inflammation of the entire finger, and enthesitis, which is inflammation of the entheses, which are the points of insertion of tendons into bone. Next, let's go through the psoriasis epidemiological screening tool. The NICE guidelines on psoriasis from 2017 suggest the Psoriasis Epidemiological Screening Tool, or PEST, as a way of screening for psoriatic arthritis in patients with psoriasis. It involves questions about joint pain, swelling, a history of arthritis, and nail pitting. A high score triggers a referral to a rheumatologist. Next, let's go through the X-ray changes. Characteristic X-ray changes in psoriatic arthritis include periostitis, which is inflammation of the periosteum, causing a thickened and irregular outline to the bone, ankylosis, which is fixation or fusion of the bones at the joint, osteolysis, which is destruction of the bone, and dactylitis, which is inflammation of the whole digit, seen as soft tissue swelling. The classic X-ray finding in the digits is a pencil-in cup appearance. There is erosion of the bones at the joint. There is central erosion at one side of the joint, giving a cup-like appearance, and the other bone becomes pointed and looks like a pencil sitting in the cup. This appearance is associated with arthritis mutilans. Finally, let's talk about management. There's crossover between the systemic treatments that are used to treat the skin condition and the treatments for psoriatic arthritis. Treatment is coordinated between dermatologists, rheumatologists, and other multidisciplinary team members. Depending on the severity, treatment may involve non-steroidal anti-inflammatory drugs, or NSAIDs, steroids, DMARDs, for example methotrexate, leflunomide, or sulfasalazine, anti-TNF medications such as etanercept, infliximab, or adalimumab, and a final option is ustekinumab, which is a monoclonal antibody that targets interleukin-12 and interleukin-23. Chapter 97: Reactive Arthritis. Reactive arthritis involves synovitis, or inflammation of the synovial membrane, in one or more joints in response to an infective trigger. Typically, it causes acute monoarthritis, affecting one joint, most often the knee, and it presents with a warm, swollen, and painful joint. A significant differential diagnosis is septic arthritis, where there's an infection inside the joint. Patients with reactive arthritis do not have an infection in the joint. The most common triggers for reactive arthritis are gastroenteritis or sexually transmitted infections. Chlamydia may cause reactive arthritis. Gonorrhea typically causes septic arthritis rather than reactive arthritis. Reactive arthritis is a seronegative spondyloarthropathy. There's a link with the HLA-B27 gene. It's more common in patients with HIV, and HIV needs to be excluded in patients who present with reactive arthritis. Let's go through the associations. Reactive arthritis is associated with bilateral conjunctivitis affecting the eyes, and this is non-infective conjunctivitis, anterior uveitis, which also affects the eyes, urethritis, which is inflammation of the urethra, and this is non-gonococcal, meaning it's not caused by gonorrhea, and circinate balanitis, which is dermatitis to the head of the penis. A Tom tip for you: the classic triad of conjunctivitis, urethritis, and arthritis are remembered with the mnemonic can't see, pee, or climb a tree. Finally, let's talk about management. Patients presenting with an acute, warm, swollen, painful joint need to be treated according to the local hot joint policy. Septic arthritis needs to be excluded. Antibiotics may be given until septic arthritis is properly excluded, as this is a serious life-threatening condition. Joint aspiration is required. This involves taking a sample of the synovial fluid from the joint, which is sent to the lab for microscopy, culture, and sensitivity testing for infection and crystal examination for gout and pseudogout. Management of reactive arthritis after septic arthritis is excluded involves treatment of the triggering infection, for example chlamydia, non-steroidal anti-inflammatory drugs or NSAIDs, steroid injection into the affected joint, or systemic steroids may be required, particularly where multiple joints are affected. Most cases of reactive arthritis resolve within 6 months and they do not reoccur. Recurrent cases may require DMARDs or anti-TNF medications. Chapter 98: Ankylosing spondylitis. Ankylosing spondylitis is an inflammatory condition affecting the axial skeleton, mainly the spine and the sacroiliac joints, causing progressive stiffness and pain. It's also known as axial spondyloarthritis. It's part of the seronegative spondyloarthropathy group of conditions that also includes psoriatic arthritis and reactive arthritis. The main affected joints are the sacroiliac joints and the vertebral column joints. Inflammation causes pain and stiffness in these joints. It can progress to spine and sacroiliac joint fusion in advanced disease. There's a strong link with the HLA-B27 gene, and around 90% of patients with ankylosing spondylitis have this HLA-B27 gene. It's thought that less than 10% of people who have the gene will go on to get ankylosing spondylitis. The condition is more common in men, but women can also be affected. Let's talk about the presentation. The typical presentation is a young adult male in their 20s. Symptoms develop gradually over at least 3 months. The main presenting features are pain and stiffness in the lower back and sacroiliac joint pain in the buttock region. The pain and stiffness is worse with rest and improves with movement. The pain worsens at night time and in the morning, and it may wake them up from sleep. Patients will wake up with stiffness that takes at least 30 minutes to improve once they get moving. Additional symptoms and problems include chest pain related to the costovertebral and sternocostal joints, enthesitis, which is inflammation of the entheses, where the tendons or ligaments insert into bone, dactylitis, which is inflammation of an entire finger, vertebral fractures presenting with sudden onset new neck or back pain, and shortness of breath, which can be related to restricted chest wall movement. Let's talk about some associations. There's a long list of associated conditions, and the key ones can be remembered with the 5 A's mnemonic: anterior uveitis, aortic regurgitation, atrioventricular block or heart block, apical lung fibrosis, which is pulmonary fibrosis of the upper lobes of the lungs, and anemia of chronic disease. Next, let's talk about Schober's test. Schober's test assesses spinal mobility. With the patient standing straight, the L5 vertebra is located and a point is marked 10 centimeters above and 5 centimeters below this level, 15 centimeters apart from each other. Then the patient bends forward as far as possible and the distance between the points is measured. A length of less than 20 centimeters, meaning a 5 centimeter increase from standing straight, indicates a restriction in lumbar movement and helps support the diagnosis of ankylosing spondylitis. Next, let's talk about investigations. The key investigations include inflammatory markers, for example CRP and ESR, which may rise with disease activity, HLA-B27 genetic testing, an X-ray of the spine and sacrum, and an MRI scan of the spine, which can show bone marrow edema early in the disease before there's any X-ray changes. So let's talk about the X-ray changes. A bamboo spine is the typical X-ray finding in the later stages of ankylosing spondylitis, where there's fusion of the sacroiliac and the spinal joints. X-rays in ankylosing spondylitis can also show squaring of the vertebral bodies, subchondral sclerosis and subchondral erosions, syndesmophytes, which are areas of bone growth where the ligaments insert into the bone, ossification of the ligaments, discs, and joints, which is where these structures start to turn into bone, and fusion of the facet, sacroiliac, and costovertebral joints. Finally, let's talk about management. The rheumatology multidisciplinary team will manage patients. Treatment aims to control the symptoms and preserve function. Medical management may involve non-steroidal anti-inflammatory drugs or NSAIDs, for example naproxen, which are first line. Anti-TNF medications are second line, for example adalimumab, etanercept, or infliximab. Third line are monoclonal antibodies against interleukin-17, for example secukinumab and ixekizumab. And another third-line option is upadacitinib, which is a JAK inhibitor. Intra-articular steroid injections may be considered for specific joints. Additional management involves physiotherapy, exercise and mobilization, avoiding smoking, bisphosphonates to treat osteoporosis, and surgery may occasionally be required for severe joint deformity. Chapter 99: Systemic Lupus Erythematosus. Systemic lupus erythematosus, or SLE, is an inflammatory autoimmune connective tissue disorder. It is systemic because it affects multiple systems and organs. Erythematosus refers to the typical red, malar rash that can occur across the face. Systemic lupus erythematosus can affect anyone, but it occurs more commonly in women, Asian, African, Caribbean, and Hispanic ethnicity, and young to middle-aged adults. The condition typically takes a relapsing-remitting course, with flare-ups where the symptoms are worse and periods where the symptoms settle. The result of chronic inflammation means that systemic lupus erythematosus can shorten life expectancy, although this is mitigated with effective management. Cardiovascular disease and infection are significant complications. Let's talk briefly about the pathophysiology. Systemic lupus erythematosus is characterized by anti-nuclear antibodies. These are autoantibodies against proteins within the cell nucleus. These antibodies generate a chronic inflammatory response by the immune system, leading to the condition's features. Let's talk about the presentation. Systemic lupus erythematosus presents with many non-specific symptoms, such as fatigue, weight loss, arthralgia or joint pain, non-erosive arthritis, myalgia or muscle pain, fever, a photosensitive malar rash, which we'll talk in more detail about shortly, lymphadenopathy or abnormal enlarged lymph nodes, splenomegaly or an enlarged spleen, shortness of breath, pleuritic chest pain, which is sharp chest pain, particularly on inspiration or breathing in, mouth ulcers, hair loss, Raynaud's phenomenon, and edema or swelling, which is due to nephritis or inflammation in the kidneys. The typical malar rash is shaped like a butterfly across the nose and the cheeks, and it's triggered or worsened by sunlight. Next, let's go through the investigations. Abnormal investigation findings include autoantibodies, which we'll talk about in more detail shortly. A full blood count may show anemia of chronic disease, a low white blood cell count, and low platelets. A CRP and ESR may be raised with active inflammation. Complement component C3 and C4 levels may be decreased in active disease. Urinalysis and urine protein creatinine ratio shows proteinuria or protein in the urine in lupus nephritis, which is where there's inflammation in the kidneys due to the disease. And a renal biopsy may be used to investigate for lupus nephritis. Let's talk about the autoantibodies. Around 85% of patients who have systemic lupus erythematosus will be positive for anti-nuclear antibodies, or ANA. These can be positive in healthy individuals and those with other autoimmune conditions, for example, autoimmune hepatitis. A positive result needs to be interpreted in the context of their symptoms, so a positive ANA doesn't automatically mean systemic lupus erythematosus. Anti-double-stranded DNA antibodies are highly specific to systemic lupus erythematosus, meaning a positive result suggests SLE rather than other causes. Around half of patients with SLE will have anti-dsDNA or double-stranded DNA antibodies. The levels vary with disease activity, meaning they go up if the disease is more active and fall if the disease is well controlled, and this makes them helpful for monitoring the disease activity and the response to treatment. If you order an extractable nuclear antigen panel, this looks for antibodies against specific proteins in the cell nucleus, and it helps diagnose and distinguish between different connective tissue disorders. Anti-SM antibodies are highly specific to SLE, but not very sensitive. Anti-centromere antibodies are most associated with limited cutaneous systemic sclerosis. Anti-Rho and anti-LA antibodies are most associated with Sjogren's syndrome. Anti-SCL70 are most associated with systemic sclerosis, and anti-Jo1 antibodies are most associated with dermatomyositis. Antiphospholipid antibodies and antiphospholipid syndrome can occur secondary to systemic lupus erythematosus in up to 40% of patients with the condition. These antibodies, antiphospholipid antibodies, are associated with an increased risk of venous thromboembolism, for example, deep vein thrombosis or pulmonary embolism. Next, let's talk about the diagnostic criteria. The European League Against Rheumatism / American College of Rheumatology classification criteria from 2019 can be used for the diagnosis, and this takes into account the clinical features and the presence of antibodies. Next, let's talk about the complications. Cardiovascular disease is a leading cause of death. Chronic inflammation in the blood vessels leads to hypertension or high blood pressure and coronary artery disease, which can cause angina and myocardial infarction. Infection is more common in SLE, both due to the disease process and secondary to the immunosuppressant drugs. Anemia in SLE can be due to anemia of chronic disease, autoimmune hemolytic anemia, bone marrow suppression by medications, or due to kidney disease. This means a low hemoglobin could be multifactorial in patients with SLE. SLE can also cause leukopenia or low white cells, neutropenia or low neutrophils, and thrombocytopenia or low platelets. Pericarditis, or inflammation of the pericardial sac that surrounds the heart, causes sharp chest pain that gets worse on lying flat, and this is also a possible complication of SLE. Pleuritis, which is where SLE can cause inflammation of the lining of the lungs, causes sharp chest pain on inspiration or breathing in. Interstitial lung disease can be caused by inflammation in the lung tissue, and this leads to pulmonary fibrosis. Lupus nephritis, which is inflammation in the kidney caused by SLE, can progress to end-stage renal failure. Investigations include a urine protein-creatinine ratio and a renal biopsy to diagnose lupus nephritis. The renal biopsy is often repeated to assess the response to treatment. Neuropsychiatric SLE is caused by inflammation in the central nervous system, and this can present with optic neuritis, or inflammation of the optic nerve, transverse myelitis, which is inflammation of the spinal cord, or psychosis. Recurrent miscarriage is more common in SLE, and in pregnancy there's also an increased risk of intrauterine growth restriction, preeclampsia, and preterm labor. And finally, venous thromboembolism may be associated with antiphospholipid syndrome occurring secondary to SLE. So let's talk about management. Treatment aims to control the symptoms and reduce complications with the least medications and the least side effects. Sun cream and sun avoidance are essential measures when managing the photosensitive malar rash. First-line options include hydroxychloroquine, non-steroidal anti-inflammatory drugs or NSAIDs, and steroids, for example prednisolone. Treatment options for resistant or more severe SLE include DMARDs, for example methotrexate, mycophenolate, and cyclophosphamide, and biologic therapies. Biologic therapy options include rituximab, which is a monoclonal antibody that targets the CD20 protein on the surface of B cells. Therefore, it reduces B cells and reduces the production of antibodies responsible for the disease. Or belimumab, which is a monoclonal antibody that targets B cell activating factor. Chapter 100: Discoid lupus erythematosus. Discoid lupus erythematosus, or DLE, is an autoimmune chronic skin condition. It's more common in women and typically presents between the ages of 20 and 50. It's more common in darker-skinned patients and smokers. Discoid lupus is associated with an increased risk of developing systemic lupus erythematosus. However, this risk is below 5%, meaning that patients with discoid lupus have less than a 5% risk of developing SLE. Rarely, the lesions can progress to squamous cell carcinoma of the skin, a type of skin cancer. Let's talk about the presentation. The lesions typically occur on the skin of the face, scalp, and ears. They are photosensitive, meaning that they're made worse or triggered by exposure to sunlight. They're associated with scarring alopecia, which is scarring and hair loss in the affected areas. And they're also associated with hyperpigmentation, which is increased pigmentation of the skin, or hypopigmentation, which is reduced pigmentation of the skin. The appearance of the lesions or plaques are inflamed, dry, erythematosus or red, and scaling. Finally, let's talk about management. A skin biopsy can be used to confirm the diagnosis, and treatment is with sun protection, topical steroids, intralesional steroid injections, where a steroid is injected into the skin lesion, and hydroxychloroquine. Chapter 101: Systemic Sclerosis. Systemic sclerosis is an autoimmune connective tissue disease involving inflammation and fibrosis, which is hardening or scarring of the connective tissues, the skin, and the internal organs. The cause is unclear. The term scleroderma translates directly to hardening of the skin. The terms systemic sclerosis and scleroderma are often used interchangeably. Most patients with scleroderma have systemic sclerosis. However, there is a localized version of scleroderma that only affects the skin. There are two main disease patterns in systemic sclerosis: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. So let's start with limited cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis is the more limited version of the disease. It used to be called CREST syndrome, and CREST forms a mnemonic for remembering the features of limited cutaneous systemic sclerosis. C for calcinosis, R for Raynaud's phenomenon, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. And we'll talk in more detail about all of these features shortly. Next, let's discuss diffuse cutaneous systemic sclerosis. Diffuse cutaneous systemic sclerosis includes the CREST features, but it also affects the internal organs, causing cardiovascular problems, for example, hypertension and coronary artery disease, lung problems, for example, pulmonary hypertension and pulmonary fibrosis, and kidney problems, for example, glomerulonephritis and scleroderma renal crisis. So let's talk in more detail about the features. Scleroderma refers to hardening of the skin, giving the appearance of shiny, tight skin without the normal skin folds. These changes are most notable on the hands and the face. Sclerodactyly refers to the skin changes in the hands. Skin tightening around the joints of the hands restricts the range of motion and reduces the function. The fat pads on the fingers are lost, and the skin can break easily and ulcerate. Telangiectasia refers to dilated blood vessels in the skin measuring less than 1 mm in diameter. Calcinosis refers to calcium deposits under the skin, most commonly found on the fingertips. Esophageal dysmotility is caused by atrophy and dysfunction of the smooth muscle of the esophagus, as well as fibrosis of the esophagus. It causes swallowing difficulties, chest pain, acid reflux, and esophagitis, or inflammation in the esophagus. Systemic hypertension and pulmonary hypertension, or high blood pressure, is caused by connective tissue dysfunction in the systemic and the pulmonary arterial systems in the blood vessels. Systemic hypertension can be worsened by renal impairment. Pulmonary fibrosis occurs in severe systemic sclerosis, and this has a gradual onset of a dry cough and shortness of breath. Scleroderma renal crisis is a medical emergency with severe hypertension and renal failure. Next, let's talk about Raynaud's phenomena. Raynaud's phenomenon is where the fingertips change color in response to even mildly cold triggers, for example, opening the fridge. It's caused by vasoconstriction, or closing up of the vessels that supply the fingers. The typical pattern is they first turn white due to vasoconstriction, then they turn blue due to cyanosis, and then they turn red due to reperfusion and hyperemia. They go white because the blood vessels close, they go blue because of a lack of oxygen, and then when they reperfuse, they go red because blood rushes back into them. Raynaud's disease is where Raynaud's phenomenon occurs without associated systemic disease. It is idiopathic, meaning there's no other secondary cause, and it makes up 80 to 90% of patients who have Raynaud's phenomenon. Systemic sclerosis is the most important secondary cause of Raynaud's phenomenon. It's less commonly associated with systemic lupus erythematosus. Nail fold capillaroscopy is a technique to magnify and examine the peripheral capillaries where the skin meets the base of the fingernail, which is the nail fold. The signs that are suggestive of systemic sclerosis on nail fold capillaroscopy are abnormal capillaries, avascular areas where there's no blood vessels, and microhemorrhages, or small spots of bleeding. Patients with Raynaud's disease, where there's no systemic sclerosis, will have normal nail fold capillaries on capillaroscopy. The treatment options for Raynaud's includes keeping the hands warm, for example with gloves and hand warmers, calcium channel blockers, for example nifedipine, and other specialist drugs including losartan, ACE inhibitors, sildenafil, and fluoxetine. Beta blockers can worsen the symptoms of Raynaud's. Next, let's talk about autoantibodies in systemic sclerosis. Anti-nuclear antibodies, or ANA, are positive in most patients with systemic sclerosis. Anti-nuclear antibodies are non-specific, meaning they can occur in other diseases, for example SLE, or systemic lupus erythematosus, or autoimmune hepatitis. Anti-centromere antibodies are most associated with limited cutaneous systemic sclerosis. Anti-SCL70 antibodies are most associated with diffuse cutaneous systemic sclerosis and more severe disease. Next, let's talk about the diagnosis. The American College of Rheumatology/European League Against Rheumatism classification criteria from 2013 can be used to make the diagnosis, and this takes into account the clinical features, antibodies, and nail fold capillaroscopy. Next, let's talk about management. Disease-modifying anti-rheumatic drugs, or DMARDs, for example methotrexate, and biologic therapies, for example rituximab, are options in diffuse disease. Steroids may be considered but are associated with an increased risk of scleroderma renal crisis. Non-medical management involves avoiding smoking, gentle skin stretching to maintain the range of motion, regular emollients to keep the skin hydrated and healthy, avoiding cold triggers for Raynaud's, physiotherapy to help maintain healthy joints, and occupational therapy for adaptations to daily living to cope with the limitations. Medical management focuses on treating the symptoms and the complications. Nifedipine is usually first line for Raynaud's phenomenon. Proton pump inhibitors, for example omeprazole or lansoprazole, are used to treat acid reflux. Prokinetic medications, for example metoclopramide, can be used for gastrointestinal symptoms. Analgesia can be used for joint pain. Antibiotics may be required for skin infections. Antihypertensive medication, for example ACE inhibitors, are used to treat hypertension and scleroderma renal crisis. Endothelin receptor antagonists, for example bosentan, may be used for pulmonary hypertension and digital ulcers, or ulcers on the fingers. Sildenafil may be used for pulmonary hypertension and digital ulcers associated with Raynaud's phenomenon. Intravenous iloprost may be used for digital ulcers. Oxygen may be required for pulmonary fibrosis, and a stem cell transplantation may be considered in rapidly progressing severe disease, but this carries significant risks. Chapter 102. Polymyalgia rheumatica. Polymyalgia rheumatica, or PMR, is an inflammatory condition that causes pain and stiffness in the shoulders, pelvic girdle, and neck. There's a strong association with giant cell arteritis, and the two conditions often occur together. The cause of PMR is not fully understood. There are no relevant antibodies. It is more common in older, white patients. Let's talk about the presentation. Patients may have a relatively rapid onset of symptoms, for example over days or weeks. Symptoms should be present for 2 weeks before a diagnosis is considered. The core symptoms are pain and stiffness of the shoulders, potentially radiating to the upper arm and the elbow, pelvic girdle around the hips, potentially radiating to the thighs, and the neck. The characteristic features of the pain and stiffness are that it's worse in the morning, worse after rest or inactivity, interferes with sleep, takes at least 45 minutes to ease in the morning, and somewhat improves with activity. Associated features can include systemic symptoms, for example weight loss, fatigue, and a low-grade fever, muscle tenderness, carpal tunnel syndrome, and peripheral edema. Let's go through the differential diagnosis. The presenting symptoms are not specific to polymyalgia rheumatica, and there's a long list of differentials, including osteoarthritis, rheumatoid arthritis, systemic lupus erythematosus, statin-induced myopathy, myositis, for example polymyositis, cervical spondylosis, which is wear and tear in the spine in the neck, adhesive capsulitis or frozen shoulder, hyperthyroidism or hypothyroidism, osteomalacia, fibromyalgia, lymphoma or leukemia, and myeloma. Let's talk about making the diagnosis. The diagnosis is based on the clinical presentation, the response to treatment with steroids, and excluding the differentials. Inflammatory markers, for example ESR and CRP, are usually raised, but they may be normal. The NICE Clinical Knowledge Summaries updated in January 2023 advise investigations before initiating steroids. And these investigations will include a full blood count, a renal profile or Usinase, liver function tests, calcium, which could be abnormal in hyperparathyroidism, cancer, and osteomalacia, serum protein electrophoresis, which will look for myeloma, thyroid stimulating hormone to check the thyroid function, creatine kinase, which looks for myositis, rheumatoid factor to look for rheumatoid arthritis, and a urine dipstick test. Additional investigations to consider include anti-nuclear antibodies for systemic lupus erythematosus, anti-cyclic citrullinated peptide or anti-CCP antibodies for rheumatoid arthritis, a urine Bence-Jones protein for myeloma, and a chest X-ray for lung and mediastinal abnormalities, for example, lung cancer or lymphoma. Next, let's talk about treatment. Treatment of polymyalgia rheumatica is with steroids. The NICE clinical knowledge summaries updated in January 2023 recommend 15 milligrams of prednisolone daily initially and follow up after 1 week. Patients with PMR have a dramatic improvement in symptoms of at least 70% within 1 week of taking steroids. Inflammatory markers will return to normal within 1 month. A poor response to steroids suggests an alternative diagnosis. Treatment with steroids typically lasts 1 to 2 years. NICE suggest following a reducing regime of prednisolone, for example 15 milligrams until the symptoms are fully controlled, then 12.5 milligrams for 3 weeks, then 10 milligrams for 4 to 6 weeks, then reducing by 1 milligram every 4 to 8 weeks thereafter. The reducing regime can go faster or slower depending on the individual and their symptom control. Steroid-related complications include weight gain, diabetes, bruising of the skin, osteoporosis, high blood pressure, and cataracts. Additional management for patients on long-term steroids can be remembered with the "don't stop" mnemonic. Don't refers to steroid dependence, which occurs after 3 weeks of treatment, and abruptly stopping the steroids risks adrenal crisis. As the patient takes steroids for a long time, their own production of steroids shuts down, which means they're at risk of adrenal crisis if they stop taking the steroids. S stands for sick day rules, and this refers to the fact the steroid doses may need to increase if the patient becomes unwell. Normally when you're unwell, your natural production of steroids increases. Patients on long-term steroids don't have as much natural production of steroids, so their doses may need to increase to compensate. T is for treatment card, and patients should carry a steroid treatment card that alerts others that they're steroid dependent. O is for osteoporosis prevention, which may be required, for example, bisphosphonates and calcium and vitamin D. And P is for proton pump inhibitors, which should be considered for gastroprotection, for example, omeprazole. Chapter 103: Giant Cell Arteritis. Giant cell arteritis, or GCA, is also known as temporal arteritis. It's a type of systemic vasculitis affecting the medium and large arteries. There's a strong link between giant cell arteritis and polymyalgia rheumatica. It's more common in older, white patients. The key complication of giant cell arteritis is vision loss, which is often irreversible. Therefore, it needs prompt recognition and management. So let's talk about the presentation. A unilateral headache is the primary presenting feature. Typically, this is severe and located around the temple and the forehead. It may be associated with scalp tenderness, for example, noticed when brushing the hair, jaw claudication, which is aching in the jaw when chewing, blurring or double vision, and loss of vision if untreated. The temporal artery may be tender and thickened on palpation, and when palpating, the pulse may be reduced or absent. Associated features include symptoms of polymyalgia rheumatica, for example, shoulder and pelvic girdle pain and stiffness, systemic symptoms, for example, weight loss, fatigue, and a low-grade fever, muscle tenderness, carpal tunnel syndrome, and peripheral edema. Let's talk about making the diagnosis. The diagnosis is based on the clinical presentation, raised inflammatory markers, particularly ESR or erythrocyte sedimentation rate, which is usually more than 50 millimeters per hour, a temporal artery biopsy, which shows multinucleated giant cells, and duplex ultrasound of the temporal artery can show the hypoechoic halo sign and stenosis of the artery. Next, let's talk about management. Steroids are the mainstay of treatment. They should be started immediately before confirming the diagnosis to reduce the risk of vision loss. There is usually a rapid and significant response to steroid treatment. The dose and choice of steroids depend on whether there's visual symptoms or jaw claudication. For example, 40 to 60 milligrams of oral prednisolone daily if the patient has no visual symptoms and no jaw claudication. But if they do have visual symptoms or jaw claudication, they may be treated with 500 milligrams to 1,000 milligrams of intravenous methylprednisolone daily. Once the diagnosis is confirmed and the condition is controlled, the steroid dose is slowly weaned over 1 to 2 years. Other medications that are considered